Yes, ma'am. Go ahead.
Okay. Can I start now?
Yes.
Okay.
Yes.
I welcome you all to the day 2 of Foxy ICOG certification program. Can we have the invocation song to start with?
Yes.
After that only we can share it.
The volume
No audio.
is not there.
I think audio is not there. You can just take
Audio is-
Darshan. Darshan ले लो और start कर दो.
Okay.
Go ahead, please.
Okay. So heartfelt gratitude to Dr. Sunita Tandulwadkar ma'am, President Foxy ICOG, Dr. Parag Binawale sir, Chairperson ICOG, for this opportunity, and a great secretarial support from Dr. Sarita Balerio ma'am and Secretary General Dr. Suvarna Khadilkar ma'am. I also extend my thanks to Dr. Shobha Gudi madam for a much needed and a nicely crafted program. So day 1 was a great success with very good attendance and great take-home messages. I hope the audience and especially the postgraduates who have joined must have benefited a lot. We now look forward to have a great interactive session today also. Now I request our co-coordinator, Dr. Reju, to introduce Dr. Sheila Mane ma'am to give the welcome address.
You're mute, Riju.
Apologies. A very good evening to all for this day 2 of Foxy ICOG certificate course. And it's my honor to invite Dr. Sheila Mane ma'am for her welcome address. Dr. Sheila ma'am is ICOG Vice Chair elect and past VP Foxy.
Chair elect.
Chair elect. Yes, madam. Welcome, ma'am. Welcome, ma'am, for your welcome address.
Thank you, and I thank Dr. Sunita as well as Dr. Parag for this opportunity, and Dr. Ashok Kumar. And it's very happy to see that even a topic like this, contraception, also is been spreading so much of good message, and people are willing to join. And I congratulate the team, Dr. Shobha Gudi and her team, Dr. Kavita, Dr. Riju, for taking up this initiative, as it is a very important part of it, because we know that unless and until we talk about it to our own colleagues, they will be not sensitized. I know it's very easy to say, yeah, yes, I know. But when you do these type of programs and try to sensitize people, then the importance of it is known to everybody. And today's topic, you are also covering PPIUCD and Implanon, and which these programs are there in all the government hospitals currently. Implanon in few hospitals in Karnataka, in Delhi, and in Bengal, like that. But BPIUCD program is mainly happening in government hospitals, where the private practitioners are still not
Ma'am, you're not audible.
Sheila.
and that type of certificate courses will definitely help to spread the message. Yesterday, I think we had very senior speakers. Today also,
our phone is getting hanged, I think.
Yeah.
find that all these yesterday's topic like MEC criteria will definitely throw so much of light for today's medical disorders in pregnancy and contraception, because which is on the rise, and really people get confused, and you feel bad when they come for MTP. So it is very important that post delivery, post abortal, because we have an opportunity to talk to them, we spread this message, or a cafeteria approach. For example, just now I had a patient, I told her about Implanon, about IUCD, about LNG IUS. And I said, say, it's like a coffee. You choose whichever you want. You want Nescafe brew or you want a cappuccino. Okay, all are good. So it is very important to counsel them and talk about it. So I congratulate the whole team and I wish all the best for today's webinar. And I know all the speakers definitely do a great job today. And thank you for the invitation once again.
Thank you,
you
ma'am,
so
for
much.
your blessings and the words of wisdom. Can I have the slide, CV slide? Next slide, please. Next slide, please.
Yes.
I would like to invite Dr. Ashok Kumar, sir, Professor and Head Department Obs Gynae, Ram Manohar Lohia Hospital. He is also Vice Chairperson, ICOG, has edited many, is the editor of many journals and has many research papers to his credit. Sir, may I request you to please address the August gathering?
Yeah, thank you, Dr. Kavita. Good evening to all. First of all, I thank Foxy ICOG President Dr. Sunita Tendulkar and Foxy ICOG Chairperson Dr. Parag Binewale for organizing these type of courses for the benefit of all the members. And further, to add to this initiative of ICOG, I would express my sincere thanks to Dr. Shobha Gudi and Dr. Durga Das and Dr. Rachna, coordinator of this course under the banner of ICOG. It is a great initiative, pregnancy by choice, not by chance. A good title, and it gives you the message what all it will cover, and all the program which has been made and very well programmed also over the 3 days as by Dr. Shobha Gudi madam. It is very well appreciated yesterday also, and I hope today and tomorrow also the program will be very well appreciated by the audience and all the members. So thank you very much, and I thank all the faculty who have taken interest and spared their valuable time to take part in this program. And I am very well eager to listen to the talk by Dr. Atul, who is very well charged up and waiting. And just without wasting much time, we will just switch over to the program. Thank you very much.
Thank you, sir, for your words of wisdom. Now, with the permission of Dr. Sunita Tendulkar ma'am and Dr. Parag sir, I declare Day 2 ICOG certification program on pregnancy by choice, not by chance, open. So, can I have the next CV of Dr. Rachna? I would like to invite Dr. Rachna Jaju, who is the chairperson MTP and Family Welfare Committee, and is the member of MPH committee.
Kavita ma'am, we can skip this introduction part and I'll just be giving the overview of day 2.
Okay,
Good
welcome.
evening all, and we welcome you on behalf of the Foxy ICOG certification course for day 2. Yesterday was a power-packed performance with lecture, symposium and panel, and we are very glad that nearly 200 delegates had joined in yesterday and more were PG students. So we are very overwhelmed with this response. And for day 2, we have Dr. Parag sir, Dr. Ashok sir, and Dr. Sheila Mane madam to bless us. And we have exciting line of lectures which are lined up by eminent speakers and seniors from the field of OBGY. We have a procedural workshop on long-acting reversible contraception, and then we have a reverse panel on contraception conundrum in special situations. So exciting line of lectures lined up, which is followed by post-test, which has MCQs of 20 MCQs and which is mandatory to get that certificate. So stay tuned and thank you so very much. I'm sure Kavita and Riju are doing an excellent job. So stay tuned, guys. Thank you.
Why are we seeing Uday's picture all the time? Uday, what have you done?
I'm supposed to chair the lecture which you are taking.
Oh,
So
okay.
I'm waiting to listen to you. I don't know why it is coming all the time. I can't see my own picture.
Thank you so much, Dr. Rachna Jaju ma'am. So in pills we trust when timing is right and choice and science give every woman might. So with this, let's begin the first session. And to chair the first session, I would like to invite chairpersons Dr. Alok Devdas sir and Dr. Uday Thanawala sir. Dr. Alok Devdas, sir, has been the past Vice President Foxy, past Chairman ICOG. He's an inventor of paperless partogram, growth tape, descentometer, and it's lots more. I welcome Chairperson Dr. Uday Thanawala, sir. He's a consultant at Navi Mumbai and past Chairperson ICOG, past Vice President Foxy. Welcome, sir. I request to
Thank
kindly
you.
take over the session and invite our first speaker, Dr. Atul Ganatra, sir.
So, thank you very much for the introduction, and thank you, Shobha, for having me here. And I don't know if Dr. Devdas is there. I don't see him. Has he joined?
So I just had a word. He'll be joining soon, sir.
Okay. So we have two very interesting lectures in this session. The first is contraceptive pills, old and new, and here Atul is here to speak about the uh, contraceptive pills. And even though we've had these pills for a very long time, there's a certain hesitancy, even as yet, in women to take it and in doctors to prescribe it. So I think after listening to Atul, we will be more uh, proactive in prescribing the OC pills and managing them very well. So Atul is a consultant OBGYN and an endoscopist in Bombay. He is the director of the Ganatra Nursing Home and a consultant at the Fortis Hospital in Mulund. He was the president IAGE in 2024, Secretary General IAGE 22 to 23, Vice President Foxy from 20 to 21, besides all the other various things. Yes, Bas, Atul, enough for you. You are very well known anyway. So please go ahead with your lecture before we have the next lecture by Saraswati. Thank you so much.
Thank you. Thank you, Uday. Thank you, Ashok Kumar, my teacher, Dr. Sheila Mane, Dr. Shobha Gudi, Kavita Riju, Rachna. Thank you for inviting me here. I'm sorry I'm pushing for time. I have to start a surgery in time.
Sorry to interrupt, sir. Dr. Devdas has also joined.
Okay, Dr. Devdas,
Yes.
good to see you after a long time. It's going to be difficult to cover the entire session of COCs in about 15 minutes, but I'm going to just highlight some salient features on what every gynecologist should know. I hope you can see my screen now.
Yes, sir.
So for those who haven't known or read Professor John Gilbaugh is one of the most interesting, fascinating gynecologists I've ever met from the UK. His books on contraception have been an eye-opener. He's probably one of the biggest authorities on contraception in the world. And this is what he said once: having one less child is the biggest contribution anyone can make to leaving a habitable planet. And I think this says it all. We have to offer contraception at every opportunity available to us and offer them as a cafeteria approach. Speak about every modality of contraception and see to it they choose. We do not tell them what to choose. We only suggest and the patient chooses. My topic today is going to be COCs, newer, older, which, when, and why. This is the story of the unintended pregnancies in our country. Planned births are only 43%. The rest of them are unintended births, induced abortions, miscarriages, unintended pregnancies, miscarriages from intended pregnancies. And this is what was published in the Lancet. This UNFPA article said unintended pregnancies are a significant public health issue in India. Over 21 million such pregnancies occur annually. These pregnancies are associated with poorer maternal and infant health outcome, including lower utilization of maternal health care. And a study found that 70.1 unintended pregnancy per 1,000 women aged between 15 and 49 in 2015, indicating that almost half of the country's pregnancies are unintended. And this is the famous 2015 Goodmakers article. This is what the article says: that India had 56 million abortions in 2015 among 6 states and the whole country, whereas the government reported only 16 million abortions, which means almost 74% of abortions were conducted outside the healthcare facility. And this is where we lacked we failed completely. Though our MMR has come down, and remember that we had a mortality rate of 12% from unsafe abortions, and now that mortality rate has come to 8% or maybe a little less now, just because medicated abortions, because gynecologists did not do anything. Over 10 million women in the US use COCs, out of which 86% use OC pills. 58% of them on oral contraceptive pills use them in part because of acne and anemia. This is now officially allowed by the FDA. However, if you look at our country, less than 5% use the COCs. This is because the gynecologist practicing does not have the time to talk to their patients. They only say contraception le lena. We do not tell them that they could use a barrier contraception. We do not tell them that a POP is available so that it doesn't affect breastfeeding, IUCD, LNG intrauterine device, the implant, like what Dr. Sheila Mane was just telling us. And I think 70% of patients still follow what is called as female sterilization as the only modality of contraception. And this is where I think our job today is to see that we have a chart in front of us which has all the contraceptive facilities available, and we offer it to them with salient side effects. This is again another chart which said that only 3,000 patients use OC pill in this particular study. And look at the male sterilization factor. Male, 4,000. Female sterilization, almost 21,000. So this is the incidence of what? 34%. 1/3 of unplanned pregnancies is due to non-use of contraception. And when we took a study, or rather a patient said they thought there was no risk of pregnancy, they were not worried. We will see unplanned, undesired intercourse, stop using because the method was not suitable. This is where again our job comes. No contraception available, too many other problems, thought of AIDS but not pregnancy, being careful, did not know where to go. And this is a lovely article published in the Human Reproduction. Every gynecologist must have this MEC criteria book and the MEC criteria wheel in their consulting room, because if the patient comes with a medical problem, we know that we have to refer to this wheel and see to it that we provide them with the best and the safest contraception. And that is where the WHO MEC criteria talks about category 1, 2, 3, 4. For example, for a woman who has just delivered, a COC will be a category 4, whereas a POP will be category 1. If a patient is an epileptic, a COC will be a category 4, and an LNG IUS or a Depo-Provera will be category 1 and 2. I don't have the time to go into the details. This is how you need to classify the yes method, the no method. The 3 and 4 obviously are methods that we cannot use. What is the type of contraception that women desire? It should be affordable. It should have fewer side effects. It should be discreet. It should regulate cycles in patients with PCOD, because the patient does not get periods for about 2 or 3 months and she suddenly comes with a pregnancy. Ideally, they would want also something that they don't take every day, because they forget. A patient who delivers is so busy with looking after the child that she does not remember to take the pill, whether it's a POP. For her, and LAC is the best combination, a long-acting reversible contraception. Effective with low-dose hormones, steady, constant delivery. It clears acne. It should be taken monthly, weekly, or daily. If you see the one which says daily, the preference is much lower in our country. And everybody who's interested in talking about contraception or learning contraception should read this article, Combined OC Pill, an update. This is a 2024 article from Zurich, Switzerland. COCs have been available for decades. While there is a wide knowledge of certain risk factors or precautions to be taken during their use, thanks to the scientific progress, new insights continue to emerge that significantly influence the use of COCs. We have to give COCs for many conditions. It could be as a result of abnormal uterine bleeding, irregular cycles. It could be in adolescence. It could be in pregnancy and lactation, perimenopausal women, which are designated as the special population, because a woman between the age of 35 and 45 feels that anyway, I'm not going to become pregnant, and they become careless. And it's not uncommon to see a 40, 41-year-old lady who comes to us with a pregnancy. Women with gynecological problems, these are my favorite to use OC pills because that's the regulation of cycle is the best. And now we have something different for every indication. If she has acne, we have a different drug. If she has dysmenorrhea, we have a different drug. If she has fluid retention, we have a different drug. And of course, women with medical disorders, we have to use them with caution. Most women take OC pills to prevent pregnancy, but 14% of them use them also for non-contraceptive reasons. And they could be menstrual-related disorders such as menstrual pain, irregular cycles, fibroids, endometriosis-related pain, and menstrual-related migraine. And the FDA has now formally approved combined pills for acne for specific brands. And for those, I repeat, please read this book by Professor John Gilboa, who once told me in a conference, when I spoke, said, sir, I have about 11 patients who are on OC pills and developed a cavernous sinus thrombosis. One of them was my resident who was on the ventilator at Fortis Hospital because she was taking some Ayurvedic drug plus an OC pill and did not follow up at all. And he says, Atul, all medicines are safe. Some women are dangerous. So we have to identify these women who have thrombophilia, who have lupus, who have SLE, so that these patients don't take it. And I'll show you my way or our way of looking after them. The combined oral contraceptive pill, one of the primary side effects of CHC is the increased risk of venous thromboembolism, which is greatly influenced by personal and family medical history. And here is where the personal and family medical history is extremely important. One of my own relatives developed DVT during pregnancy, but when we went to the history, her mother had a stroke at 30. Her sister died of a CVA, and hence the composition of COCs also plays a crucial role with the lowest increased risk expected in combinations of ethinyl estradiol, second-generation progestogen such as levonorgestrel, as well as combination of estradiol and normegestrel. This is not available in our country as of now, but the LNG is probably the safest when it comes to the risk of DVT. So this Bahu of our house, I told you, she had an IUFD at 34 weeks. 6 weeks after delivery, she had ovarian vein thrombosis. And now she's also had an MI. Strong family history. When we worked her up, she was lupus. These are things and these are patients we need to identify. Caution should be taken when counseling a patient, specific patient population. For instance, patients with BRCA1 and BRCA2 mutations experience a significant further increase in their risk of breast cancer using COCs, and this risk increases further with the duration of use. Mind you, there is a difference here. The incidence of developing a DVT or a cavernous sinus thrombosis is most common in the first 1 year and in young patients. Whereas when it comes to CA breast, the use and the incidence increases with age. However, we still prescribe almost about 10 or 15 OC pill prescriptions every month. When counseling patients with migraines, it is essential to consider significant increase in the risk for stroke associated with COC use, particularly in patients experiencing migraine with aura. Progesterone-only pill containing desogestrel have shown to reduce the frequency of migraine attacks and do not elevate the risk of stroke. Emergency contraception. Patients seeking advice for using emergency contraception. The timing of initiation of COC intake should be taken into account due to the risk of interactions between both the methods, especially those who've taken ulipristal. There has to be a gap of at least 5 days. An emergency contraception, just one slide, unprotected intercourse with up to 72 hours, you could take a levonorgestrel. After 72 hours to 120 hours, a copper IUD or ulipristal. And of course, you need to use a barrier contraception to prevent STI. The estrogen component with the COC is dispensable for inhibition of ovulation, as the progesterone component alone is adequate to achieve this effect. The inclusion of the estrogen component aims primarily at minimizing the breakthrough bleeding that occurs during the COC application. That is why we know with the POP, that is the progesterone-only pill, patients can have intermittent spotting. Even when they take Dynogest, they can have intermittent spotting. The minute you add estrogen, that stops. Estrogens are the main reason for a vascular complication such as venous thromboembolism. And that is why every hormonal prescription of ours has this stamp on it, which says, inform us if you have headache, giddiness, nausea, vomiting, cramps in legs. Because we use it for IVF to plan the cycle. When we do batch IVF, we use it for menorrhagia. We use for various indications. I use a lot of cyproterone acetate for acne and even drospirenone for acne. COCs containing ethinyl estradiol valerate EV2 and estradiol E2 have been accessible in the European Union for more than a decade. All the three forms of estrogen induce the synthesis of clotting factors as well as fibrinolactic factors in the liver, causing imbalance in the coagulation system. And hence, Dynogest should be prescribed, or Dynogest containing Ocipil should be prescribed in caution to those patients who have a history of DVT. We have only one estrogen now, maybe we have two estrogens, but we have 4 generations of progestrogens. That is at one time, ethinyl estradiol was the only estrogen, progesterone kept changing. So it could be first generation like norethindrone, second generation called levonorgestrel, third generation called norgestimate or gestrodin and desogestrel, and an unclassified progesterone that is the drospirenone and cyproterone acetate. So I would use this in a patient who says I have a lot of fluid retention, because this has anti-mineralocorticoid and anti-androgenic activity, and cyproterone acetate in a patient who has a lot of acne and hirsutism. This is another slide talking about the same. The most important slide is this one. This is the classification of progesterone, which progesterone causes high androgenic activity. So whereas levonorgestrel and norgestrel are least when it comes to DVT, but they have a high androgenic activity, and drospirenone has the lowest, it is anti-androgenic and has anti-mineralocorticoid activity. So this is something that I would use in a patient who wants treatment for acne. The risk factors, this has to come in the history of every patient. Venous clotting, stroke, heart attack, thrombogenic conditions, hypertension, smoking more than 35 years, positive family history of blood clot, migraine with aura, severe gallbladder or liver disease. Again, we classify the risk depending upon what they have, and you can give them a score. Arterial and venous cardiovascular events, these complications typically occur in young users and new users. And this is something that we need to caution them. And that's why that stamp is very important. In contrast, arterial events typically occur when arteries are already compromised by atherosclerosis. Thrombus formation on the plaques potentially promoted by the effects of COCs. Noteworthy, the risk factors of arterial events include age greater than 35, smoking, hypertension, other conditions. The risk of DVT, we've also already mentioned. The risk of DVT in healthy COCs users is 2 to 3 per 100,000 women years. The DVT risk during pregnancy would be much higher. That is 58 to 60 events per 110,000 women years. This is not uncommon, and we see a lot of these patients at our hospital in Fortis. VTE varies depending on the combination of estrogen and progesterone, the combination with the smallest increased risk, and therefore safest options is one with estrogen, that is EE, and LNG, that is levonorgestrel, as well as combination of E2 and normegestrol. This is the combination that I would give in a patient who has any history. Breast cancer, an elevated risk of breast cancer in COC users with an additional 13 cases of breast cancer per 100,000 women years. Overall data suggests low risk. And it's been proved that patients who are taking Ocipils are monitored better, And that's why you pick up these patients much faster. Progesterone and risk of breast cancer. There is this Swedish studies that says even putting an LNG IUD can increase the risk of breast cancer. These patients need to be monitored. And finally, this is my second last slide. This is the combination that I would go by order. Ocipil containing ethinyl estradiol, levonorgestrel in a patient with a risk of DVT, and norethisterone, desogestrel, drospirenone, which is Yasmin and Yaz, or many other products now. If I have to use an anti-androgenic and anti-mineralocorticoid activity, particularly PCOD patients. Dynogest I would use in a patient who has endometriosis and dysmenorrhea, and the others which are not available in our country. And finally, friends, women are not dying of diseases we cannot treat. Women are dying of diseases which we can treat. This is what Mohammed Fatala said. They are dying because societies have yet to decide that their lives are worth saving. Thank you very much.
Thank you so much, sir. What a wonderful closing statement. I request Dr. Dev, sir.
Yeah, Dr. Devdas can give his comments. Yes, Richard. Yes.
Dr. Devdas, sir, are you able to unmute yourself?
Yes, I have unmuted.
Yes.
Am I visible or audible at all?
Good
So
evening,
you're
sir. We
audible.
can't see you.
Audible, yes. Visible, no.
I don't know what to do.
We can hear you, sir.
But we can hear you very clearly, sir. You can give your message. You can speak, sir.
Well, I think in a very short time, Dr. Atul has done a very good job. But my overall comment will be, I think he has made everybody cautious about COC. I think it is a little, overcautious. Listening to this lecture, you will think not twice, thrice before prescribing OCP. In contrast, WHO is recommending OCP over-the-counter drug. No examination, no history, nothing. So this too seems contradictory. And I think this is the main point, but COC has been recognized or labeled as the best drug of last century for women. So considering that, this is, in my view, also the best contraceptive, better than POP and others. So I would still go for COC with normal routine screening, but one need not be so scared because WHO has very large data as to allow to be purchased or even free OCP like acros. So it is not all that bad. However, routine screening for CA breast may be self-examination, and also every 5 years pack to be done, because after 5 years use, the increased incidence of cancer cervix due to increased susceptibility to HPV 16 and 19. Well, that's all I have to say. And congratulations to all of you, especially Dr. Atul. Thank you.
Thank you, Devdas, sir.
So my job was to bring about the salient features of history taking, which we must not miss.
Correct.
It is difficult to talk about the positive aspects in 15 minutes.
Yes.
For residents who are going to prescribe this medication should know what can happen if the prescription goes unattended to, and the choice is to be given to the patient.
Thank you, sir.
Thank
You so much. Our next speaker was Dr. Saswati Sanyal, who will be speaking on POPs, but due to some family emergency, she is not able to join us. So I would request Dr. Shobha Gudi ma'am, who has nicely crafted this program, to take her lecture.
Yeah. Can I be?
I'm just
Made
going to
host,
stop
please.
sharing my screen.
Yes, thank you.
I think I have already done that, have I not?
Yes, sir. Yes, sir.
You have.
Yeah, okay. I'll take your leave. Sorry, I have to just rush for a surgery.
Thank you, Atul. Thanks
Thank
a lot.
Okay.
Thanks for accepting. And you are right to caution, and we will take forward the message. Thank you very much. So my screen is seen, Riju?
Yes.
Yes, ma'am.
Yes.
Yes, ma'am.
Kavita, yeah.
Yes, ma'am.
So thank you, Sankalp champions, for being there. Just a minute. I think I have not shared the correct one. So sorry. It is the correct one, not the correct slide, that's all. Yeah, so we are missing dear Shashwati today, but she has more urgent family commitments. I shared now? No?
Ma'am, you haven't shared.
No,
We
we
can't see your
Okay.
can't.
slides.
All right, I'll share. I think I did not reshare the screen. Few seconds. Yeah, so I do agree with Devdas sir that it's important to um, become a regular prescriber of hormones in order to develop that courage which is required to be safe in prescription. You require to follow the medical eligibility criteria. Yesterday we had a fantastic panel discussion on MEC, and I feel that most of us who are prescribing follow the MEC criteria. Yeah. So COC is in fact the commonly used pill all across the world. It is the commonly used pill. Is there any echo? No, no. Am I okay?
It's fine.
Yes.
It's fine.
Yeah, okay. All right. So progesterone-only contraceptive is actually a boon for the woman in her reproductive age group, and it is available in various forms. We are already aware about all the long-acting methods, but the one short-acting method of progesterone-only pills is very underutilized, and it is a very safe option for a woman. The pill contains very low doses of the synthetic progestin, and sometimes also the natural hormone progesterone, also the synthetic derivative of it. Oral progestin mono preparations, originally they were brought in because in the immediate postpartum period, the risk of thrombosis being very high for women, and also because estrogen containing pills can alter the milk quality, and therefore progestin only became a choice. And it was termed as mini pill because it contained very low doses. So to get introduced to this, primarily progesterone will prevent follicular growth to a lesser extent than estrogen, but it will do that. It will have a negative feedback abolition or to the higher centers, hypothalamus and pituitary, and follicular growth will not occur, though it is less potent than estrogen in achieving this. But it also makes the cervical mucus very thick, and it induces endometrial atrophy in the long term, and it will prevent implantation. So it's a highly effective form of contraception if it is taken continuously. And estrogen effect in the pill is contributes to inhibition of ovulation, and that we have just now covered. Progesterone, when it comes as the pill, has been available in these forms as the norethindrone pill. We don't have it, but levonorgestrel, desogestrel, and drospirenone pills have been there in our market. Okay, and the most common formulae today, as I said already, norethindrone, LNG, desogestrel, drospirenone. The mechanism of action we just now covered. These are the mechanisms. Okay. And then you can see the blue, which is the progesterone. And when we give progestin only hormonal contraception, you can see that, you know, the exogenous progesterone maintains a very high level, and it has all the effects that we just now spoke of. And because of this, the natural pulsatility of all the pituitary and the ovarian hormones gets abolished. So the first generation norethindrone 0.35 milligram is 28 tablets, continuous use, is actually available in the West, not for us. The second generation LNG 28 pills with no pause, continuous pill 0.03 milligram was available in India, but right now, even in the government basket, now it is not available. Third generation desogestrel 75 micrograms, 28 pills with no pause is available for us, and we have the fourth generation drospirenone of 4 milligram per day, 24 active pills, 4 placebos, during which there will be a period, is available for us. It can be started on the first or second day of menstruation. And if there is more than 5 to 7 days lapse in the first 48 hours, then it has to be kind of, you know, there has to be a backup. it can be started from any day if this concept of backup is understood. The missed pill should be taken immediately, but in case of the levonorgestrel pill, the pill-free interval is lesser. In drospirenone, it is longer. In desogestrel also, it is lesser than drospirenone. I'll come to it. So in any of these events, if there is vomiting or diarrhea, or if the individual is more than 3 hours late, especially for LNG, then they have to take an extra pill or they have to have a backup method. Emergency contraception can be provided for these women in those 48 hours, and then they can actually, except for ulipristal acetate, and then they can go ahead with within 48 hours of initiation of POP if there is a need, if there is an unprotected intercourse, then I think that emergency contraception will be necessary. Now, side effects of cyst formation or irregular bleeding is fairly common. Acne flare is seen with the older progesterone, not with desogestrel and drospirenone. But then there are fewer side effects than COC, and long-term effects so far have not been documented. There are some drug interactions, just like COC, for example, women on anticonvulsants, and that might reduce the efficacy. And are there any contraindications? Just like COCs, if there is a suspected pregnancy or an undiagnosed AUB or an active breast cancer or a liver disease, or the woman has had bariatric surgery or has convulsions on treatment, we have to be cautious about this. What is the monitoring or the basic evaluation? Just like COCs, we do not require much except for the original, the body mass index becomes important, because in very obese women, there is a chance that efficacy will be less. Also, there will be a slightly higher concern about probably the independent cardiovascular risk for complications, but this will be much less than for COCs. The failure rate in a typical user, it is possible that is slightly higher, but in a perfect user, it will be less. The Pearl index of 6 to 8 is in traditional POP, but with the newer POPs, the Pearl index is much less. There is a 3-hour missed pill window, but the problem happens because of irregular bleeding. If the timing is missed, there will be some irregular bleeding. The desogestrel POP, there is a 12-hour missed pill window. As I said, the missed pill window will be different for different progestins. For traditional levonorgestrel, it is 3-hour, desogestrel 12-hour, and drospirenone, it is 24 hours. We need to remember and we need to share with the woman that these do not protect against sexually transmitted infections. And in settings where these infections are suspected to be higher, they have to be cautioned for barrier use. Okay, so the MEC criteria in known medical problem is rather encouraging. So whenever you feel that there is a setting of 3 to 4 MEC criteria for COC category, you'll be surprised to see for POP, it is 1 or 2. So majority of the times when you find women who are smokers or have migraine, or have cardiovascular disease, we can still prescribe POPs, provided the underlying medical condition is under very good control. It is also heartening to know that POP is rather a method of choice for women within 6 months of delivery, because it is absolutely safe for a breastfeeding woman. Okay, so it is something which can be given to the woman as an immediate postpartum contraception to be started as soon as she starts her sexual activity, or at least 6 weeks later. So desogestrel POP also has some beneficial side effect, favorable effects on the menstruation, making it more comfortable. About drospirenone, there has been a thought that it is emerging as a very useful pill, because nearly all women can use this safely at any age, even if they have had a recent abortion or ectopic pregnancy, or do smoke, or are anemic, or have varicose veins. And the return of fertility is fairly quicker than the other progesterone only methods. And this 4 milligram of drospirenone can be used on the day when the previous COC would have started. So it can be used as a good switchover method from a COC or a transdermal patch or an injection. On the day when the next injection should have been given, you can just start off the POP. And whenever there is an IUD removal or implant removal and there is a need to switch to another method, POP can be used. So in other words, the POP, progesterone only pill, is a very good bridging contraceptive method. There is a concept which is known as bridging method, and POP are excellent bridging methods. Okay, so this is a study which shows that at recommended doses there is no effect on the breastfed infant. This is another study which has women with high BMI and does not show it shows equal efficacy of drospirenone 24/4 regime. This shows cardiovascular safety for drospirenone. So POPs are safe and effective, require strict timing. That is why I have been speaking about the timing. It should be started as early as possible in the menstrual cycle. And then it is very ideal for women in whom estrogen cannot be used, which we have spoken of just now. Okay. So this is the classification which I was speaking about, the 3 ones. I think we have spoken about the regimes. These are the comparative activities, and I think the more we become familiar with the molecule which we are prescribing, the better is our conviction with which we prescribe, the better is the strength of the prescription and the strength of the counseling which goes along with it. So if you look at drospirenone, it has got good progesterogenic estrogenic activity, and it has anti-androgenic activity very mainly, also has anti-mineralocorticoid activity. So this is favorable, as well as desogestrel is also a favorable molecule, though its profile is a less versatile than drospirenone. Okay, so I have been over this. This is happening because this combination of my PPT with Dr. Shashwati's. So I will be rather taking you through to the end of the presentation by saying a little more about drospirenone application. I think I have also come to the end of my timing also. So this is about day 1 start, and for 24 days, no tablets from 25 to day 28, and subsequent pack of the same day of the week as the first cycle. That means after 4 pill-free days. This is important because a woman who is actively lactating, for example, she is breastfeeding, she may or may not get a period with withdrawal of this 4 milligram drospirenone. So irrespective of whether there is a bleeding or not, she should start after 4 days in order to have a continuous efficacy. That is what I wanted to bring in. This kind of treatment also improves the menstrual flow, reduces the menstruation. It also has some favorable impact on the on dysmenorrhea, etc. The discomfort. Also, I must bring in here a very salient feature. Please disregard this slide. I just wanted to add here one factor, one very significant beneficial side effect is a relief of premenstrual tension, which is seen very well with drospirenone containing combined oral contraceptive pills, but is also found to be lesser when POP containing drospirenone is being used. That is because of the anti-mineralocorticoid effect of drospirenone. So this is a slide which is showing the 24 hours pill-free, the margin. That means after 1 day also, if the missed pill is taken, the contraceptive efficacy is maintained as far as drospirenone is concerned. So these are more studies which are showing that there is a better safety for drospirenone, and safety windows are better, and that is why the missed pill window is longer. and very good for postpartum, which I have spoken. Bleeding patterns are better. All right. So irregular and abnormal uterine bleeding will improve. There is supposed to be some antihypertensive action, but the evidence for this is isolated studies, so I'm not focusing on that. It is also thought that its effect on the anticoagulant, the procoagulants is very minimal, and therefore see the hematoserological parameters and does not affect the balance between procoagulatory and anticoagulatory factors, and therefore so far it has not been linked to thrombotic episodes. And metabolic parameters, it is quite safe for women with dyslipidemias. It is safe in women with carbohydrate intolerance or diabetes, which is well controlled. Long-term effect has not shown any change in bone mineral density because these are very low dose. So in summary, drospirenone can be used, the POP can be used with a Pearl index of 0.51, and this improves bleeding profile, decreased unscheduled bleeding, 24-hour missed pill safety. Backup is required, is not required unless 2 active doses are missed, and there is an advantage of anti-mineral corticoid and anti-androgenic effects. Maybe women with PCOS will also benefit, and treatment adherence and acceptance of this treatment has been found to be good. Compliance has been found to be good. Even with risk factors of VTE, so far no thromboembolic episodes have been found. So with past history of DVT, this is category 2. Please remember that. And which is category 3 for COCs. Decreased blood pressure is seen and can be used in obese. So with that, I end my deliberation, and I hope that I was able to convince that this is a very sound option for women looking for contraception, especially in the postpartum period. Thank you very much. I've stopped sharing, right? Yeah.
Yes, ma'am. Thank you so much, ma'am. I request Dr. Thanawala sir to kindly give his expert comments.
That was a wonderful lecture, Shobha, and as usual, very crystal clear messages. And I think most of the people have got what you were saying. So I doubt if there are any questions, but I think there is one question in the chat box. If someone can just read it out, and Shobha will be able to answer it.
Yeah, Shreya is asking withdrawal bleeding. Well, this is not an appropriate drug for withdrawal bleeding because it doesn't contain that potency of short duration in which withdrawal can happen. I think if you wanted to prepone or postpone the cycle, you can accordingly reduce few of the doses and give, but that will be slightly experimental. So
better to use a OC pill.
Maybe, or a short dose of higher dose progesterone, which we usually do, a natural macronized progesterone. If I have understood it correctly, she wants withdrawal bleeding in a patient having severe weight gain and androgenic side effects, even with short-term use of other progestins. Yes, it can be used in obese women with androgenic side effects, provided she needs contraception. So this is more a drug which is floated as a contraception rather than for management of hyperandrogenic features, for which, of course, low dose oral contraceptive pills of 24 days regime is what is suitable. Please do not confuse this with the combined oral contraceptive pill, which has drospirenone of 3 milligram along with ethinyl estradiol of 20 microgram. That is what is useful for PCOS women with hyperandrogenic features. With this pill, if suppose the woman desires POP only, and suppose there is a contraindication for estrogen, it can be used, but it may not have the same hyperandrogenic effects as the combined pill. It may have definitely some benefit. Yes.
Sir, any comments, Dr. Devdas?
Sir, please unmute yourself. Dr. Devdas, sir, please unmute yourself. You are muted.
Is it audible now?
Yes, sir.
Yes, sir. We can see you now, sir.
Am I visible also?
Yes, sir.
Sir, you are very much visible.
Oh, thank you. Now, I have one small comment that difficulty in taking this tablet has to be taken at the same time every day, which is socially very difficult. And that's one. The other thing that
Sir,
they tend
isn't
to
that
be-
easy, sir? I thought that was okay, sir. Okay.
And the other thing that some women develop cystic changes in ovary.
Yes.
They are not inconsequential, but as soon as it appears in ultrasound, she gets anxious and remains anxious and keeps
Yes.
having ultrasound, which is
Mhm.
not. I think these are the two comments I have.
Yes.
And the other
Thank you, sir.
occasional spotting.
Yeah, that is
which-
something which even Archana Kurana has asked. With POP, will menstruation be regular? Well, one thing which we have to accept and we have to bring into the counseling is progesterone-only methods are not great cycle regulators. They are very good contraceptives, but the only kind of tool which leads to very regular cycles is COC. The combined pill is the champion for regular cycles.
Yes.
All else can have slight irregularity, slight spotting, but the spotting should not be considered as menstruation, is what we must tell our women, because they have a lot of practices in their life which revolve around menstruation. So they have to be strictly told that spotting is not menstruation, only flow is menstruation. Probably, and then also that it's not harmful, it does not indicate disease, it is the effect of the drug. So I think that counseling plays a role, and what has been found with progesterone only pills is compliance is better with counseling, and it really is long lasting, I think, because I think the side effects, other side effects are very less. So in that way, it is a winner in many ways. I think we must prescribe more.
Good, thank you.
Thank
Thank you,
you,
sir.
sir.
Thank you,
So that's
Shobha.
a very interactive and an interesting session. We now move on to the next session. Please, can I have the slides, the chairpersons of the next session, the CVs? So I would like to invite Dr. Meena Samant. She's a senior consultant and head of the Department of
Thank
Gynae.
you, Dr. Kavita. I'm here. Thank you for inviting.
Thank you,
Yeah,
ma'am. Can I have the next slide? I would also like to invite Dr. Mala Srivastav, ma'am. She's a senior consultant and professor, gynae endoscopic and robotic surgeon in Sir Gangaram Hospital. She was the president.
She will just join shortly.
Yeah,
So we
yeah.
can start.
I'm here, Dr. Kavita.
Thank
Right.
you. Please, I would like request you to invite the speaker, Dr. Meena, ma'am, please.
Yeah. Okay, good evening, everyone. Thank you, Doctor, for inviting us here today. The first talk is in this very practical session by Dr. Prachi Dikshit, who's assistant professor in AIMS Nagpur, ex-associate professor in NKPSIMS and in Lata Mangeshkar Hospital, Nagpur. And she has many accolades. And I think what I found very interesting was the interest or area, passionate about quality improvement in medical education and research, and ensuring respect of human rights of patients irrespective of any bias, holistic health and sustainable living. So Madam is going to talk about PPIUCD, which we know has its own great benefits. So we'll hear it from Dr. Dikshit. Over to you.
Thank you so much for your kind words. I'll start sharing my screen.
We can't see your slides yet.
Yeah, can you see my slides now?
Yeah, please put it on slideshow.
Yeah, sure. Yeah. Is it visible properly now?
Yeah.
Thank you so much. So with your kind permission, I start. Good evening, everyone, and respected dignitaries, respected chairs, and august audience. I bring greetings from Nagpur Obstetrics and Gynec Society and from AIMS Nagpur. And here we move on to the next session of this prestigious training session that is about PPIUCD. And also this is the first session of the procedural workshop. So basically we're going to focus upon the skill part of the insertion of the PPIUCD, which is considered not to be very difficult procedure, but still with a lot of inhibitions around it, I think we should be technically very sane when this method. So the learning objectives of this session are mainly going to be the skill-based session for insertion of PPIUCD. Now, just a sec. I'll talk later. So the mainstay of family planning program in India is women's control over their own fertility, and the postpartum IUCD are one thing which offer the best. That's why they were included in National Family Planning Program from 2009 to 10. And India has become a global leader in PPIUCD services. The overview, but if we see as an overview, we find that the still IUCD is used very infrequently, that is in just 1.5% of the women will prefer to use IUCD. So definitely there's something which is missing, maybe from the recipient side or from the people who are counseling for the acceptance of IUCD, or maybe the project which has been launched since 2009, we have to look back into what the problems. So yes, PPIUCD is very good, and if by expert hands, it offers an opportunity at the right time, that is at the postpartum period, when the beneficiary is very receptive and is still in the healthcare facility where you can use this method. We have to emphasize at this time only that the fertility of this woman can return as early as 4 weeks after the delivery of the baby and after the abortion by about 10 days. So this is the best time when you can offer the contraceptive services to the woman who's very receptive at this time. So the basic that one needs to have before we move to the skill session is, I think all of you should know about what are the various types of IUDs, what are the various copper-containing devices. The two main copper IUDs which are offered by the Government of India, that is copper 380A and copper 375, free of cost. The effective duration of each, where copper 380A can have efficacy for 10 years, whereas 375 for 5 years, their mechanism of action. Their shelf life, that once packed, you have to check that for how long they are still and you can use. What are the common side effects that we will discuss at the end? What are the best timings of insertions? That is, what is interval IUCD? What is postpartum IUCD? What is post-abortal IUCD? We will basically focus on postpartum IUCD currently. And the medical eligibility criteria for IUCDs. So the best part about postpartum IUCD is most of the contraindications of that is the category 3 and 4 MEC of IUCD are themselves they do not happen like if we talk about PID. So in a postpartum woman, you will not see any acute PID. So most of them are themselves cancelled, and the eligibility criteria which we need to focus during PPIUCD insertion are that immediate post-placental, that is within 10 minutes, postpartum less than 48 hours, or intracesarean section. So these women fall under MEC category 1. If they have chorioamnitis, prolonged rupture of membranes, that is rupture of membranes greater than 18 hours, any sign of puerperal sepsis or unresolved postpartum hemorrhage, then not insert, they will fall under category 3 and 4, and you should not insert PPIUCD in such situations. So you have to always reassess at the time of insertion. Now, before venturing into PPIUCD insertion, we should not surprise the patient just after delivery or at the time of delivery, but there has to be a preparedness. And the best time to prepare the patient for accepting or offering her any method of contraception during the postpartum period is during the antenatal period only. So during the first assessment has to be done during antenatal period, that is initial assessment for assessing whether she is eligible. Second assessment immediately prior to insertion for assessing no adverse changes as a result of delivery. That is, she has PPH, or she had fever lately, or she came with PRN. And then, of course, the insertion can be done in the eligible candidates. So When we talk about preparing the patient, that is requesting them for or offering them the cafeteria, whatever will be available in the postpartum period, then what principles we need to follow? We should be non-judgmental, respectful, ensure the privacy and confidentiality of this patient. Contraception has not to be forced into. Sometimes, especially in public setups, we get very judgmental about the contraceptive choices of the women, which should not happen. Simple, culturally appropriate language should be used. Good verbal and non-verbal interpersonal communication, maybe talking about personal experiences and maybe making them communicate other women who have been using these contraceptions. Brief, simple, and specific information with key messages should be given. And opportunity for client to ask questions, express their concerns, because many of them will say that many of their relatives had some or the other problem which they need to clear it out, that what is the myth and what is the truth about it. Effective use of audiovisual aids can be used, ensure the woman understands. So coming to the point per se, that is the postpartum IUCD insertion. When do we call it postpartum? That is, either it could be post-placental, when we deliver within 10 minutes after delivery of placenta, or immediate postpartum, that is within 48 hours after delivery. But at this point of time, I would again like to emphasize that post-placental is the best type of postpartum IUCD insertion, because it is a single time event, which is just single event which is taking place for the woman. Like there is no another encounter with the doctor which is required, which may be painful after episiotomy. If you like within 48 hours with an episiotomy stitch, if you do a PS examination, that will be a painful experience. So preferably within 10 minutes, when the local anesthesia effect of the episiotomy local anesthesia is still there, at the same time you can offer the post-placental IUCD insertion. Of course, you have to follow all the steps of active management of third stage of labor or bone man, and you have to ensure that the patient is having no active bleeding when you do the insertion. So moving ahead with the actual steps of the insertion. So of course, client preparation, we had talked about counseling in antenatal period, early labor, and take a verbal consent, which can be enough. Shaving is not required. The gentle clipping of genital area, clipping of hairs could be done if required. Absolute sterility should be the then the provider preparation. The provider should follow all aseptic precautions. The patient should be clean, draped properly, ensure adequate privacy during the procedure, and communicate, talk to the patient all the while when you are performing the procedure. So the things which will be required for PPIUCD insertion, the tray of PPIUCD is very, very simple and should always be available in our birthing centers. So they include 2 sponge holding forceps, a bowl which should contain some sterile solution for sterility like betadine or Savlon, cotton balls, gloves, a long handled forceps for insertion of PPIUCD, which is Kelly's forceps, Sims speculum, and if required, sometimes, especially with copper 375, you may require scissors for cutting the long threads. So this is Kelly's forceps, which is a long handled forceps and slightly curved at the tip, as you can see, and therefore it is easy to reach to the fundus of the postpartum patient using the Kelly's forceps. So the first step is visualization of the cervix. Insert a high-level disinfected sterile speculum to visualize the cervix after the delivery. So this is how a postpartum cervix will look like. And you have to see that there's no active bleeding. Whatever the cervical lacerations, etc. were there, if they were there, then they have been taken care of. Then cleaning of the cervix and vagina with the cotton swab soaked with appropriate antiseptic. And once or twice, you should clean the cervix and vagina. And then after the povidone solution, betadine has been applied, then wait for 2 minutes and discard the swabs. So cleaning of the vagina, cleaning and draping the patient. Then with the speculum in place, you have to grasp the anterior lip of the cervix, and sponge holders should be used for any post-abortal or postpartum patient, as the cervix is very soft. So we have to use the sponge holder for holding the anterior lip of the cervix. The sponge holder with which we have cleaned has to be discarded, and a fresh sponge holder should be used for holding the anterior lip of cervix. Speculum must be removed at this time, if necessary, leaving the ring forceps gently to one side, because now you want to unload the copper T. So you may remove the speculum for some time. Now, so holding the anterior lip of the cervix with sponge holder is the next step as shown in the image. Now, how to load the IUCD? So you have to open the pack of the IUCD almost 1/3, and you have to hold the IUCD with the no touch technique. You don't have to touch the IUCD. Insert and with IUCD 380A or 375, you have to remove every other thing like the card and the plunger, inserter, whichever is available, whichever is present, and only the copper T has to be kept inside the packet. So insert PPIUD insertion forceps inside the packet and grasp the IUCD using no touch technique. So here I show the opening of the pack, and then everything, all the contents of the pack are removed except the IUCD. And then we insert our IUCD inserter, the forceps, long forceps, and hold the IUCD right inside the pack. Now, how it has to be held? IUCD should be held just at the edge of the PPIUCD, slightly at the corner. I will show you the picture. Take out the PPIUCD insertion forceps along with the IUCD from the packet gently, and you have to hold it firmly so that it does not fall down. So this is the technique by which you hold the copper T with Kelly's forceps, and you can see the curve of the Kelly's forceps, which will be directed towards the other side. The next step is insert PPIUCD in lower uterine cavity. Apply gentle traction on anterior lip of the cervix using ring forceps, and insert IUCD held with PPIUCD insertion forceps into lower uterine cavity. Avoid touching the walls of the vagina. So still the no touch technique be carried forward. So slightly straightening the canal, you insert the PPIUCD into the open cervical os. And once you are inside the os, and you feel the first resistance, at that point of time, you can remove the sponge holding forceps with which you were holding the anterior lip of the cervix. So you have to advance the IUCD inside the uterine cavity, and there will be a ring kind of bulge from the posterior wall of the uterus post-delivery. In the post-delivery uterus will have a slight bulge in the posterior wall where you may feel the first resistance. So move the left hand of the woman's abdomen to the woman's abdomen, which is covered with a sterile drape, and push the uterus upwards. This is to straighten out the angle and the curvature between the vagina and uterus so that the instrument can easily move upward toward the uterine fundus. So here you can see that there is a slight bulge from the posterior uterine wall between the angle of the vagina and the uterus. So if you press upon the abdominal wall and push the uterus slightly up, then you see that that bulge disappears and it is easy to insert the PPIUCD forceps up to the fundus of the uterus. So the provider should keep the forceps closed so that the IUCD, all this while you have to take care that you have held the PPIUCD forceps closed, otherwise you can drop the IUCD somewhere in the mid cavity. Gently move PPIUCD insertion forceps upwards towards the fundus following the curve of the uterine cavity. So you have to reach the fundus, and with the hand which is on the abdomen, you have to palpate the fundus that you have reached the fundus. The forceps should be felt through the fundus, the resistance. Then, so the placement of the IUCD can be high fundal. So you have to confirm that the end of the PPIUCD insertion forceps has reached the fundus. When it reaches the uterine fundus, then the resistance will be felt. And this is the point when you will tilt your hand a little. The hand has to be tilted a little. Drop the PPIUCD there. So you have to open the PPIUCD insertion forceps, tilt it slightly towards the midline and release the IUCD. So this is the IUCD, and here you can see that arrow is being shown for the tilt, and you have to release the PPIUCD. Once you've released the PPIUCD, you have to follow the curvature of the uterus, and through the outer curvature, you have to come out so that the threads do not entangle in the inserting instrument, and gradually you can come out. So slowly remove PPIUCD insertion forceps from uterine cavity, keeping it slightly open at all times. Take particular care not to dislodge the IUCD as forceps are removed. Keep stabilizing the uterus until PPIUCD insertion forceps are completely out of the uterus. So gradually sliding it through the lateral wall, you have to come out of the uterus. And at the end of the procedure, you have to again examine the cervix to see if there is any bleeding or if IUCD is protruding from the cervix. If it is protruding, then you have to remove the IUCD and preferably reinsert a fresh IUCD. If you are very sure it is, but it's always advisable to insert a fresh IUCD. It is important to check that the IUCD strings are not, as with copper T380A string should not be visible. With copper T375, sometimes a slight amount of thread might be seen, which should be cut at absolutely at the level of the cervix. So at the end, again, you will examine the cervix. So we have talked about this. I think the string should be cut at the level of the cervix. So again, going through the pictures, from the step 1, inspection of the cervix,
Prachi, sorry to
postpartum.
Can you please
Pardon?
Can you please wind up? Your time is up.
Okay, so I think we have seen this already.
Very nice,
For
Prachi.
interest,
Very nice. Yeah.
yes, ma'am.
If you,
Just winding up.
you will conclude, no, in another, I think, time.
Sure.
Yeah,
Ma'am.
yeah.
For the intracesarean insertion of the IUCD, the same procedure with the forceps can be followed, or you can use the hand to insert the IUCD. The steps which are being shown, so you can hold the IUCD between 2 fingers. Post-abortal insertion after surgical evacuation and size of the uterus up to 12 weeks. Steps are similar to interval insertion. Here, we should not use the sound. The Carman's cannula can be used as sound. In second trimester, we will do the same procedure as we follow in PPIUCD. So there are wonderful videos from FIGO which are available online, and we can always revise those videos whenever we are inserting IUCD. I think post-insertion as steps, we have to talk to the patient, give her the card. At the time of delivery, we have to give her the instructions, what instructions have to be followed, explain how to check for expulsion, especially in the first few cycles, give written statements in the card when and which type of IUCD was inserted and till when the efficacy will last. We should tell her about the common side effects that can happen, slight amount of pain, maybe irregular cycles for the first 3, but with lactation amenorrhea, this is also prevented in PPIUCD. Data recording for all the cases should be very good, and following the proper technique, the side effects, the chances of expulsion and side effects will be minimal. But we should talk about the side effects which can happen, especially if she misses the period anytime after lactation amenorrhea period, she should report the healthcare facility. And what are the conditions where we can go for IUCD removal whenever she wants the next child, or there is evidence of IUCD displacement or any personal reason. So I think here I can conclude we should follow the reference manual for IUCD services if we are interested in it. The Ministry of Health and Family Welfare has updated in 2018, which we can use. Thank you so much for the wonderful opportunity, Shubha ma'am, and I'm open for the questions if any.
Thank you, Dr. Prachi. Request Mala ma'am to please give the expert comments.
All speakers can answer the chat box question in the chat box for paucity of time.
Yeah. I would like to congratulate Dr. Dikshit. It's a very good presentation, and you highlighted the important points where we have to take a grip of the so that it doesn't fall out, and the curvatures we have to take care of. Sometimes we tend to fumble them. So congratulations.
Very
Thank
nice.
you.
Yes. Yeah,
Thank you
Meena,
so
I
much.
agree with you. I agree with you that she did a very good job, and the tricks for reducing the rates of expulsion is, of course, fundal placement of the PPIUCD. Very nicely done. Thank you.
Thank you so much, ma'am.
Next, since Dr. Mala will be joining us shortly, I will take this opportunity to introduce Dr. Meenakshi Ahuja. She is Senior Director in Obs and Gynae at Fortis Love in New Delhi. And she's also into cosmetic gynecology, President Delhi Society, Academic Secretary, Delhi.
I think I'll start, Dr. Meena.
Yeah,
I think we are
okay,
already
okay.
running
What
short
do
of
you?
time, and I'm trying my best to share my screen, and I'm having a little this thing. So you can share your entire screen or a window allowed to share screen.
You must
And
open the presentation on the desktop.
it's open on the desktop.
Then choose the window in which your presentation is seen.
Your screen sharing तो आ रहा है.
उसमें एक में रहेगा आपका presentation रहेगा.
This, can you see this thing now?
We are seeing. You can do. Yeah, we can see. Yes.
Okay, thank you. So I'll be talking about Implanon next, or Nexplanon as it's known all over the world. This is the clinical information and training workshop slides, because there's a proper protocol on how it has to be put. So since it's just about a 15-minute thing, I will be quickly giving a small introduction and then moving on to how to exactly insert the Implanon next. It's an OPD procedure. It's very easy, but I think just the fear on how to use it becomes very difficult for all of us to start off. And in all honesty, it's as simple as putting in a cannula, because that's exactly what it feels like, and you can compare it with. So this is a subdermal long-acting hormonal contraceptive effective for up to 3 years. It's a progesterone-only implant in a disposable applicator. It's called Implanon NXT in India, and otherwise it's called Nexplanon all over the world, probably because of some compliance issues. So the core is made of ethylene vinyl acetate copolymer, and it contains 68 milligrams of etonogestrel, barium sulfate to make it radio opaque, and that is the only difference between Implanon and Implanon NXT, which is the new generation. The size is about 4 centimeters and it's about 2 millimeters wide. And so when I explain it to the patients, I tell them it's smaller than a toothpick. The applicator will give you a preloaded sterile applicator, which is single use and disposable. And so it acts by ovulation. It's a progesterone device, like you saw etonogestrel. It's an ovulation inhibitor with changes in the viscosity of the cervical mucus also. It's rapidly absorbed into the circulation after insertion, and the ovulation inhibiting concentrations are reached within 1 day. The maximum serum concentrations are from day 1 to 13 and then gently decrease with time. At the end of year 1, it is about 200 picogram per ml, and at the end of year 3, it is about 156 picogram per ml, which is also effective as a contraceptive. So there is no bone density change. And the bleeding patterns, you have to generally counsel your patients, because 60% of patients will see no bleeding abnormality, 20% will say that they are having amenorrhea, and 20% may say that their cycles are irregular. And I think that's the most important thing on counseling a patient when you put in the Implanon next, so that you don't need to remove it. If the woman is aware that her cycle is going to get irregular and still it's a very safe, effective and low dose contraceptive, and that your cycle is going to get back to normal the day it is removed, I think there is a lot of compliance happening. So the counseling as far as the Nexplanon is concerned is very, very important. So coming to the, yes, and it can be used in breastfeeding because it's a progesterone device. So you will not put it in known or suspected pregnancy, active venous thromboembolic disorder, known or suspected sex steroid sensitive malignancies, history of benign or malignant liver tumors, history of severe hepatic disease, undiagnosed vaginal bleeding, and hypersensitivity to the active substance or any of the excipients. And if pregnancy occurs during use of it, it should be removed. So coming to so here I would also like to mention that the difference between this and the Mirena, number one, Mirena or the LNG device that goes into the uterus, this goes in the arm. And the second is that stays in for 5 years, this stays in for 3 years. And the third is that the efficacy remains the same throughout. The efficacy starts waning after 3 years, and it is related to the body weight. So if you're putting it in an obese patient, please do remove it in 2.5 years rather than 3 years. Also, usually we say that the LNG device may take 3 months to settle, and the bleeding pattern settles after 3 months. Here, usually the bleeding pattern, if it is fine, will usually stay the same for 3 years. And if there's any change, it's really not going to settle after 3 months. So your patient just needs effective reassurance and counseling. So the first step would be discussing benefits, risks, and possible side effects. It's highly effective. No method of contraception is 100% effective. The return to normal menstrual cycle will be within a month. If inserted correctly, can be removed at any time. It should not be used for longer than 3 years and needs to be removed at the end of that time period. Talk about the contraindications, side effects, especially emphasizing the alteration of the bleeding pattern, and remind the patient that it does not protect against STIs or HIV. We've already covered this. And you explain the patient the insertion and removal procedures. The good thing is that she knows that the implant is going to be there, so she can actually palpate it. Sometimes difficult removal and scars or complications may occur. However, if placed correctly, they will not occur, and provide sufficient time for a woman to review, consider, and ask questions. Usually the best time to put the Implanon would be when she's just having her periods or just have them, so that we don't put it if a patient is accidentally pregnant. It can be put at 40 days of delivery also, which is the time when I'm using it very often, or post a bottle. So you should confirm that the woman's history has been obtained, the woman is not pregnant, she understands the benefits and risks, and she has received the copy of the product information, including in the packaging. So coming to the materials for insertion, this is something which can be comfortably done in the OPD. It is done under aseptic conditions. You require an examination table, that is your examination table that you're using in the OPD, some sterile surgical drapes, your gloves, an antiseptic solution, a sterile surgical marker, local anesthetic. Also, when you're inserting it, if you have the benefit of you have a Prilox gel available, or even an anesthetic spray, that is as good, and the local anesthetic injection is not required in these cases. Needle and syringe, that also only if you're going to inject the LA, sterile gauze, adhesive bandage, and pressure bandage. So in the clinic also, this is probably something extra that we need. That is that we normally don't keep bandages in a gynae obs OPD, so you should keep that. And a normal pressure bandage, and probably a little, the tape that we put, band-aid sort of thing to put over the when we are putting it. So you position the woman prior to insertion. So to help make sure the implant is inserted just under the skin, the healthcare professional should be positioned to see the advancement of the needle by viewing the applicator from the side and not from the arm. From the side view, the insertion site and movement of the needle just under the skin can be clearly visualized. What this means is that if you're putting it in the non-dependent arm, so normally we obs and gynae make our patient lie in the opposite direction that the physician makes the patient lie. So the easier way is that you make the patient lie down with the head on the side of the footlight that we use, so that the light comes on her arm and her left arm is facing her rather than her right. So it's easier to put it there. So that's the first thing. Secondly, when your patient is lying on the table, the easier way to visualize the putting the Implanon is that rather than standing on the patient's head and trying to put it, take a stool and sit next to the patient and then insert it. It's much easier because you are at eye level to the insertion in the arm. Identify the insertion site. This is probably the most important slide in the whole thing, which is at the inner side of the non-dominant upper arm. So what this means is actually on the inner side of the arm here, the insertion site is overlying the triceps muscle at about 8 to 10 centimeters, so about 4 inches from the medial epicondyle of the humerus. So I think when I'm talking about this, all of you should feel your medial epicondyle and take one hand like that, go about 10 centimeters up, and then about 3 to 5 centimeters or 2 inches below the sulcus between the biceps and the triceps. So you can feel the sulcus between the biceps and triceps. That's where the great vessels are. So we want to avoid it, and that is why we must go low, below into the near the triceps muscles. The location is intended to avoid the large blood vessels and nerves lying within and surrounding the sulcus. If it is not possible to insert the implant at this location, it should be inserted as far posterior from the sulcus as possible. The implant should be inserted subdermally just under the skin, exactly like a cannula, except that in the cannula you have to direct it into the blood vessel, and here you have to stay completely away from where you think the blood vessels are. So mark the insertion site with the surgical marker. Make 2 marks. So the first mark is the spot where the etonogestrel implant will be inserted, and mark a spot at about 2 inches proximal, that means towards your shoulder, to the first mark, so that when you're inserting, you know in which direction to go. The second mark will serve as a direction guide during the insertion. After marking the arm, confirm that the site is in the correct location on the inner side of the arm. Clean the skin with to the guiding mark with an antiseptic solution. So again, like I said, anesthetize 3 ways. Either you can use an anesthetic spray, you can put a Prilox gel, or inject 2 ml of about 1% lidocaine just under the skin along the planned insertion tunnel. Remove the sterile preloaded disposable Implanon next applicator carrying the implant from the blister. So it's in a package, you just remove it. Hold the applicator just above the needle at the textured surface area and remove the transparent cover on it. You will see the white colored implant when you look through. So it's like a cannula in the needle inside the cannula. And once you see it, don't touch anything. There's a slider on top like you can see in the picture. So don't touch the purple slider. Gently just insert the needle and later only retract the needle and prematurely then only release the implant from the applicator. If the purple slider is released prematurely, restart the procedure with a new applicator. You will not pull back the applicator till the needle is well in place. So to make sure the implant is inserted just under the skin, position yourself to see the needle. That is, if you're sitting down, you'll be able to see the needle very comfortably. And so you see it from the side and not from above the arm. From the side view, you can clearly see the insertion site and the movement of the needle just under the skin. With your free hand, stretch the skin around the insertion site towards the elbow. The implant should be inserted subdermally just under the skin. Puncture the skin with the tip of the needle slightly angled less than 30 degrees, as you can see in the second diagram. Once you have punctured the skin, lift up the skin and decrease the angle. So insert the needle till the bevel, that's a slanting opening of the tip, is just under the skin. And if you inserted the needle deeper than the bevel, withdraw it till you reach the bevel only. And then lower the applicator to a nearly horizontal position. Lift up so that you can see the needle under the skin and move forwards. So to facilitate the subdermal placement, lift the skin with the needle while sliding the needle to its full length. You will feel a slight resistance, but it goes in beautifully. It doesn't trouble you at all. Because usually no one has had any surgery at that point. If the needle is not inserted to the full length, the implant will not be inserted. So please go right in till the complete implant. That means till the needle that you can see is inside. And then all you have to do is the needle should be pulled back if you're going in too deep. And then once you've gone in completely, then you're just going to pull back the applicator. So you keep the applicator is on top in the same position with the needle inserted in its full length. If needed, you may use your free hand to stabilize the applicator. Unlock the purple slider by pushing it slightly down. Move the slider back till it stops. Do not move the applicator while moving the purple slider. And the implant is in its final subdermal position. The needle is locked inside the body of the applicator and the applicator can now be removed. So if the application is not kept in the same position during the procedure, or if the purple slider is not moved fully back, the implant will not be inserted properly. So then it will protrude from the insertion site. If the implant is protruding from the insertion site, you will have to remove the implant and then do this again with a new applicator. Once you've seen it happening, you will never need it again. So we also have that with the videos. Probably if someone needs a training, you can just talk to the Organon people and we can arrange the video demonstrations also online. That's also possible. Apply a small adhesive bandage or the band-aid on the insertion site. See that the implant, you can feel it from both the ends. And by palpating both ends of the implant, you should be able to confirm the presence of the 4-centimeter rod. You ask the woman to palpate the implant, apply a pressure bandage. The woman will remove the pressure bandage in 24 hours and the small band-aid after 3 to 5 days. give her the user card, put in the adhesive label and affix it to the woman's medical records. The applicator is for single day use only and should be disposed of in accordance with the local regulations. If the implant is not palpable after insertion, you can check the applicator. Maybe it was not done. Since it's now radio opaque, you can get an X-ray or a CT done. And obviously, there are higher end investigations available. And if the imaging methods fail, then you should definitely talk to the local organon office who will provide the appropriate protocol. So, unfortunately, they don't give us the video on this presentation. And I don't think I need to talk about the removal, although the process is very similar, but you need to make a little, I'll be talking about this imaging is not important. So when you need to remove it, that is when the patient wants it out or it's 3 years, you'll just make a nick and here. I'll just go through that also. So same equipment, except that you need a sterile scalpel and a forceps at this point and something for skin closure. So normally we use teddy strips. You can tell the patient then when you are inserting it, there's no cut. And when you're taking it out, there is no stitch to be given. Just a teddy strip is more than enough. And of course, the pressure bandage is required. So again, the woman lies there, you feel the Implanon, and you just press at the proximal end so that the distal end lifts up, put a little local anesthesia below it, give a little 2 mm cut, and then pull it out with an artery. So this is exactly what we're doing, anesthetizing the area, giving the cut, and then you see it with your eyes, and then hold it with the artery, and then gently remove the implant from the incision site. You can put the steady strips, and the woman wants another implant after 3 years, you can put it in through the same cut. You don't need to make another entry point at all. It can be used again for the next non. So after removing the implant, close the incision with a wound closure, apply a pressure bandage, and that pressure bandage can be removed in 24 hours. And the woman should restart contraception immediately after removal of the implant.
Meenakshi, we'll conclude, Meenakshi.
Yes,
Yeah?
I'm done.
Yeah.
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 So I just want to stop sharing. I want to see. I don't know how to stop sharing now. Yeah, is that you share? I think this goes off.
Down below.
Yeah, are we okay?
The chair.
Yeah. Thank you so much. I think, it just sounds very scary and difficult, but once you see the insertion video also, it becomes much easier. And I think if anyone, if there's a group or any society which is motivated, we can definitely arrange the video also.
Somebody answer Dr. Mala.
Dr. Mala, ma'am is not able to unmute.
Yeah. I can unmute myself.
Thank you.
Dr. Meenakshi, that was really a very excellent and elaborate way that you have described how to put the implant and how to remove and what are the implications and side effects and how to take care of the implant. It is one of the most common methods of contraception which is now being used. Earlier, they had their reservations how to use it, but now it is becoming fairly common and people are getting very confident about using it, as well as the gynecologist. They're also getting confidence in using it and prescribing it to their clients. Now we can move on to the next session, next speaker. Thanks, Dr. Meenakshi, for an excellent deliberation. In details, we had explained everything to everyone and made Implanon sound very easy to put and remove. So it's my pleasure to introduce the third speaker of this session, none other than Dr. Radhika Chetan. Dr. Radhika is an associate professor, Bangalore Medical College and Research Institute for more than 16 years. She has
Mala ma'am, you got muted again. Mala ma'am, please unmute. Yes.
Yeah. Dr. Radhika is an associate professor at Bangalore Medical College and Research Institute, post-graduation from Mysore Medical College, senior resident JIPMER, with many national and international publications, and she has been the master trainer for PPIUCD, CAC, DMPA, SBA project with field of interest of teaching, contraception, as well as laparoscopy in high-risk pregnancy. Dr. Radhika is going to speak about no-touch technique of IUCD insertion, LNG, IUS in tricky situations. Over to you, Dr. Radhika, for your scientific deliberation.
Thank you, ma'am. Thanks for those kind words. I hope you are seeing the screen, ma'am.
Yes.
Yeah, we can see your screen.
Please put on slideshow.
Yes, ma'am.
Radhika Krispag Muguspuru.
Ha, ma'am. So I'll just start with the PPIUCD video I'll be showing next. So this is only a short presentation on what are the tricky situations during the levonorgestrel intrauterine system insertion. So LNG IUS insertion videos are easily available on the YouTube. I mean, many people are already using it extensively. May not be for contraceptive purpose, but definitely for AUB and all that. Okay, but it can be used for the contraception purpose. The standard LNG IUS, we already know it by name Mirena. So the standard is actually, it contains 52 milligrams. We use it for 5 years. It has got more of a local action, but it can inhibit even ovulation in 50 to 60% of the women also. So we know the mechanism of action and all that. So it is the best ideal long-active reversible contraception. So that is the one which has to be emphasized for the woman. That is very important. There are a few tricky situations which I would like to discuss. So based upon, when do we time the insertion? Anesthesia is required, dilatation is required in nulliparous women, and there are some few conditions where we may find it difficult to insert. Okay, so ideally, yes, it is usually inserted within 7 days of the start of menstruation, but it can be inserted anytime during the menstruation, provided the woman has not had unprotected sexual intercourse earlier. In that case, it can be inserted anytime during the menses. Yes, immediately after the menses, insertion is going to be more easier. Okay, even after the abortion, first or second trimester, up to 7 days, it can be inserted. After delivery, by 6 weeks, it can be inserted without any difficulties. Okay, management of pain. There is no standard evidence-based medicine for the pain management for LNG IUS insertion. Simple analgesics like oral tablet of brufen or diclofenac can be given prior, 1 to 2 hours prior to the insertion. Even local anesthetic gel or spray also has been used to minimize the pain, or even paracervical block, particularly in nulliparous patients where dilatation may be, some amount of dilatation may be required before insertion. In these patients, you can give even paracervical block to facilitate to reduce the pain during the dilatation. That can be used, but generally pain management is not required for LNG IUS insertion in the paras woman. Okay, so cervical priming, again, it is not routine. It need not be routinely done for all the patients for IUS intrauterine insertion system. But for nulliparous patients, where you expect some amount of cervical stenosis, tight cervical loss, in these patients, we can use administration of misoprostol 4 to 8 hours before. Vaginal route is preferred than the sublingual route, which can help in reducing the pain related to the dilatation and also less uterine cramping after the procedure. That also can be used. So there are newer intrauterine system. So we know standard already Mirena is there, but there are some methods which are available with a lower dose of hormone. So there is one Skyla with a 13.5 milligram of levonorgestrel, and one more Kylina which is available as a 19.5 milligram. So Kylina is available in India now, though Skyla is not yet available in India for the contraceptive purpose. So these two low dose methods also can be used, particularly that preferred in the women with the nulliparous women, where because the diameter and the vertical stem diameter is actually smaller. So it may facilitate easy insertion. The cross arm diameter is actually lesser compared to the typical standard LNG IUS what we use. So this is the one advantage if you are using it for a younger women who are sexually active seeking for the contraception. Okay, or even in the nulliparous women, this can be used. So it actually facilitates easy insertion. So there are no cross-sectional studies or the randomized studies comparing the Mirena versus other low-dose methods, but they are supposed to be less painful in some of the case series which has been seen. Okay, so we already know we can use in most of the types of AUB, provided there is no intracavitary lesion. Intracavitary fibroid is not there, and the uterocervical length less than 9 centimeter, it can definitely be used with good benefit. Okay, but there are little high expulsion rates, particularly in younger age group, or when the women have got adenomyosis, leiomyoma, expulsion rates are supposed to be little higher. Okay, and sometimes we find that when they come for ultrasound, we find that it is actually not in the fundal. Particularly when you have inserted in a bigger uterus, 10 to 12 weeks uterus, a patient has come with AUB with contraception, you would have inserted the Mirena, but you find that it is actually not in the fundus. But as long as the patient is asymptomatic, she doesn't complain of any pain, cramps, heavy flow, and you see that actually the tip of the vertical stem is actually above the internal os. It need not be removed. Okay, so that is the one thing which we should remember. So there are few studies which has done by Dr. Ramesh from Karnataka and Dr. Paul from Kerala. They have also done few studies. I mean, they've done few modifications of insertion so that actually there is reduced expulsion of Mirena. Okay, so they have done, they have tied the LNG IUS to the vicryl thread, PGA thread, polyglycolic acid thread, and then using a suture passer carrier, it has been inserted. This is both combined hysterolaparoscopic approach. Okay, and then they have fixed using a suture material to the fundus of the uterus to reduce the expulsion rate. So this is some of the women who insist on keeping the uterus, okay, who are actually keen on fertility or who are actually keen on preserving the menstrual function, who are not willing for hysterectomy. A combined hysterolaparoscopic approach has been attempted to fix the LNG IUS. Dr. Paul, a publication is also there where there's only hysteroscopic, not combined hysterolaparoscopic, only hysteroscopic approach has been attempted, where LNG IUS is actually fixed to the uterine fundus. So these are some of the modifications which has been done in some of the bigger uteruses to reduce the expulsion rates. Okay, but there is not standard RCTs have not been done. Few case reports have been done using this method and they have been shown to be successful in reducing the patient's symptoms and also to improve the retainability of the LNG IUS. And we also know that for the women, even after menopause, sometimes if they need contraception, when you're giving us a HRT also, it can be used as a progesterone replacement for the woman with the intact uterus. Okay, so post-placement considerations are also very important. They have to come back for the regular follow-up at 4 to 6 weeks and also annually thereafter. So that is very important. So there may be many tricky situations which has been experienced by others. We can discuss in the chat box later. So I'll proceed with the IUCD video, PPIUCD video.
It is no touch technique, no, not PPIUCD.
Oh, sorry, ma'am. Sorry, yeah. Exactly. Sorry, ma'am. Sorry for that confusion.
No problem. No problem. This is interval IUCD insertion with no touch, because many people do not know the no touch. Yeah.
Ma'am, this strip of all the, I'm not able to forward. Just a minute, ma'am.
It is seen.
It is seen, but the problem is I'm not able to play because that strip is come below where my video options are there. Playing, all the buttons are there. It is there. All yeah. Just a minute, ma'am. Yes, I'm not now. I'm able to do it. Okay. So no, this is no touch technique of insertion of copper IUCD. So this is actually for the interval method. As madam mentioned, it is not a postpartum IUCD insertion. Sorry for that. So IUCD, this is copper IUCD done as an interval method. When the patient comes after a regular menses, she comes for IUCD insertion. So this is the standard practice what we are supposed to follow. So the two dreaded complications after IUCD insertion, after copper IUCD insertion is, one is actually pelvic inflammatory disease, PID, infection rates. And second is perforation risk, like where it indents into it perforates into the myometrium and slowly it migrates into the peritoneal cavity. So these two complications can be completely reduced based upon the training of the healthcare provider. So by using a no-touch technique of insertion, we can reduce the infection. And by doing withdrawal technique of insertion, when you're inserting, it will not indent into the myometrium and it doesn't slowly migrate into the peritoneal cavity. So both migration of the IUCD and infection rates can be reduced using no touch and withdrawal technique. Okay, so we know there are two types of copper IUCD. One is actually the copper T380A and multi-load. Both can be used as a no touch technique of insertion. So we need standard set of instruments for copper T insertion. So patient has to be counseled and you take consent. Yes, consent is not mandatory. Contraception is voluntary, but we always counsel and inform the patient. And because it's a procedure, we do take procedure-related consent. So take standard aseptic precautions while you are doing the IUCD preparation. Standard set of instruments, speculum, uterine sound, and scissors. All these are essential for interval IUCD insertion. So patient is made to lie in the dorsal position and sim speculum or even cusco speculum can be used. Aseptic precautions, take 2 betadine swabs, clean the cervix and the vagina, and then measure the uterocervical length. Okay, you need to measure the uterocervical length using a uterine sound. Okay, so this is very important to properly insert the IUCD without excessively pushing into the myometrium. So measure the proper uterocervical length. Okay, so this is after this, you will start the procedure of no-touch technique of loading. So in no-touch technique of loading, what happens is, so whatever part is in the whatever part enters the uterine cavity, so that is copper IUCD, and this part of the inserted tube should not be touched even with a gloved hand. Even if you have done the proper aseptic precautions on your hand, this part which enters the uterine cavity should not be touched with your gloved hands also. So you are loading this horizontal arms of the IUCD into the inserted tube without touching it directly. Inside the package, when it is inside the package itself, you have to load it. That is the importance of no-touch technique of loading the IUCD. Okay. So first thing, yes, you take the copper 380A package, check whether the packet is actually completely intact. It is not torn. That is, it is sterile. So that is very important. And also check the expiry date. So it is not expired. So these two are the important prerequisites which has to be done when you are doing it. Okay. So next what you have to do is you have to, so you know that parts of the copper IUCD package, one, it has a plunger. Then there is a transparent tube, inserted tube, and there is a blue gauge, and there is a copper IUCD proper. Below this is a measuring card with the measurements. So these measurements are basically required for the fixing the uterocervical length later. Okay. So first thing what you do is you have to open the package away from the IUCD. So package is opened away from the IUCD up to 1/3. So 1/3 of the package is removed. Okay. Put the plunger into the inserted tube. So this plunger has to be put into the inserted tube. So that's the first thing. You take out the plunger and put into the inserted tube. So that's the first step. You do it. Then what you have to do is get the whole system below into the middle segment so that you will be able to load the IUCD. So get the system into the middle third, slightly below, around, give some 2 to 3 centimeter gap from the upper pack. So that has to be done. Okay. Then push the measuring card back. Okay. So measuring card, you put it back and keep the IUCD in the middle segment itself. Then you start loading. Okay. Don't pinch the copper horizontal arms because you'll be breaking the packet. It will impair the sterility. So you do not try to pinch it. Only stabilize the horizontal arms with the thumb and the index finger. Only stabilize the arms first. Then you start giving pressure. So you push to the forward. You push the inserted tube forward. Don't touch the plunger at all. Push the inserted tube forward using the other hand. Okay, with the other hand, you have to push it so that it automatically starts bending. Okay, you should not pinch it. Okay, so push the inserted tube forward in the upward direction, start pushing it. Okay, then you notice that they automatically start bending. Okay, so when they have bent halfway, then it has to be pinched with the fingers. So don't try to pinch it in the beginning itself. With the forward direction, with the forward push, you have to slightly half bend it. Then it has to be pinched and take out the inserted tube and push it again so that now the horizontal arms are actually loaded. Though the technique appears slightly difficult, it actually takes less than 1 minute. Once you do it, at least 4 to 5 times practice is done. Okay, it's only the small simple tips are required for loading it. So next step is to fix the uterocervical length. So again, this also has to be done in the no-touch technique. So this one has to be at the 0. Okay. So you would have to stabilize the blue gauge. So you cannot move the blue gauge again with no touch because package will break. So you can only move the inserted tube up and below. So fix the blue gauge to the measurement. Like uterocervical length is 7 centimeter. Okay. So this gauge should be laid at the 7 centimeter. Push it back to 0. Okay. Or if the uterocervical length is 5 centimeter in nulliparous woman, the blue gauge should be at the 5 centimeter. You have to push the inserted tube to 0. So movement is only on the inserted tube, not on the blue gauge directly. So that should be kept in mind. So once you have fixed the uterocervical length, now it is the time to insert. So now again see to it that you are not touching this part of the IUCD, in this part of the inserted tube. And without touching any of the vaginal walls, you have to insert into the cervical canal. So you've already cleansed the cervix. Only then, after the aseptic precautions and checking the uterocervical length, only then you start loading this no-touch technique because copper IUCD has a memory of only 1 minute. So only after doing all these aseptic precautions, you have to do this. Then start inserting without touching any of the vaginal walls. It has to enter the cervical canal. So once it enters the cervical canal, next is actually withdrawal technique of removal. So withdrawal technique of insertion, withdrawal technique of insertion is you don't push it with a plunger. So this plunger should not be used for pushing it, because again it will go and embed in the myometrium. Slowly over months and years, it can migrate into peritoneal cavity. So that should be avoided. What has to be done is, this plunger has to be stabilized with the one finger, and inserter tube has to be withdrawn back. So you have to withdraw the inserter tube back to release the horizontal arms. Okay, so you have to, that is the actually withdrawal technique. You have to withdraw the inserter tube. So inserter tube is actually withdrawn to release the horizontal arms, and it will sit firmly on the uterine cavity. So sometimes when you're taking out the plunger, there may be slight subfundal placement. Okay, so you take out the plunger, but with a plain inserter tube. Only with the inserter tube, you again stabilize it to make it as a fundal insertion. Okay, so this is the proper fundal insertion. Take it out and cut the thread around 2.5 to 3 centimeter from the cervix. So this is the no touch technique of loading and withdrawal technique of insertion. And second is secondary push to stabilize at the fundal placement. Okay, so this is the important steps for the this thing. Okay, so 375 does not require loading of the arms, but directly you can, but only thing which is required is no touch technique of loading is mainly for the fixing of the uterocervical length. Only for uterocervical length you have to fix. Rest of the steps will be similar to other copper 380A which I showed. Okay, so this is the steps of the no touch technique of loading. Okay, so no touch technique of loading is, one is you have to fold the horizontal arms and also fix the uterocervical length without touching the IUCD proper. So that is very important.
Radhika, please wind up.
Yes, ma'am. Ma'am, I'm done. Okay, I'm stopping my sharing. So that is the no touch technique of loading. I'm not showing the removal. It is, I mean, all of you will be doing routinely. All the postgraduate students and all will be doing. There is no difficulty in removing generally.
Well done, Radhika. Well done.
Can we have the comments from the chairperson?
Dr. Radhika, you have nicely shown how to have a no-touch technique of inserting the property, and most of the people do not know how to do it. You have nicely explained how to do it, and you have demonstrated it so well. And this is so important, so that because most of the time when what happens, while the infection is inserted, while you're putting the property inside, if you're not very careful, you can introduce infection inside.
Yes.
So there has to be no touch technique in putting the property, and you have nicely demonstrated it for the benefit of all the viewers. Thanks, Dr. Radhika, for your excellent scientific deliberation.
Thank you, ma'am.
Nicely explained and nicely shown.
I would like to thank the chairpersons as well as the speakers for such an interesting and an interactive session. Now moving on to the next session. Over to you, Dr. Reju, to invite the chairpersons of the next session. You are muted.
Yeah, thank you, Dr. Kavita. Moving on to the next session on emergency contraceptive, I would like to invite the chairpersons. Dr. Sanjay Kumar Patil, sir, is a professor head of unit at Krishna Vishwavidyapith Karad with a work experience of more than 26 years and multiple national and international publications. Welcome, sir. Co-chairperson, second chairperson, Dr. Achala Batra could not join us. I request our chairperson, Dr. Sanjay Patil, to kindly take forward the session and introduce our speaker.
Good evening, everybody. Dr. Ritu Joshi, she is Senior Consultant, Fortis Escorts and Surya Hospital, Jaipur. She is Vice President, Foxy in 2014. She is the Chairperson for Family Welfare Committee, Foxy 2009 to 2012. Faculty in various national and international conferences. Organized conferences and workshops in obstetrics and gynecology.
Let's continue.
Yeah, okay, madam. Okay, she will be talking on emergency contraception. Madam, welcome.
Thank you very much. Hi, Shobha, how are you? So should I share my screen?
Yes, ma'am. Yes, ma'am.
Okay, now screen share. It will take me a second, huh? I'm a little slow at it. Can you see the screen?
Yes, ma'am.
Yeah, but I can't see it myself.
It's seen, it's not your PPT screen.
Then how do I get on to
Have
it?
you opened your PPT? Can you minimize that and open your PPT on the window screen
I'll
first?
just take a second for that also.
Yes.
Now you can see?
Yes, ma'am. Just need to put that on
Screen?
slideshow. Yes, ma'am.
Okay, I'll just get onto the slideshow now.
Yes, ma'am.
So hi everyone. It's a really interesting, how Dr. Shobha Goody has really been working so hard in the contraceptive methods and all, and I think she's really doing an excellent work. Very well organized webinar today. I mean, on this accreditation of the certificate, but we're going to talk about a very interesting part of the whole the 3-day workshop, and that is on the emergency contraception. Now, this is something which we actually really do ignore. And this is something which is very, very important, that the ignorance should not be there. So with this, I'll move forward that no woman can call herself free until she can choose consciously whether she will or she will not be a mother. We all know about the major global explosion taking place as far as population is concerned, and the main cause is the unintended pregnancies. Though we have been working very hard on the use of contraceptives, but still we have this major problem still with us. The choice of the contraceptive method is influenced by the demographic reasons, by the cultural and the economic and the social reasons. But India was one of the first countries, surprisingly, which really adopted the official policy and launched the family welfare programs. We were one of the first ones to do it. And we also know that the current prevalence rate in our country is almost 56% of the global rate which is there. So each year about 85 million women have an unintended pregnancy. So what we need to, I'm going to repeat a few slides which Atul has already shown. And this was a very, very important and one of a landmark beautiful study which was done, and it really has made us work very hard towards the control of the population. So we know the national incidence also, which Atul had specified on that. Let me omit these slides, and we must see as to now exactly to manage this world explosion of population, global explosion, what can we do? The problem is that we should effectively use a contraceptive method. And here, we find that the emergency contraceptives have really been very underutilized mainly, and especially in our country. And this slide again is a repeat what Atul has already spoken about. So let me get into what emergency contraception is. That the health professionals at all levels have ethical and legal obligations to respect a woman's right. And that is exactly what we are all planning to do today. Now, what exactly is emergency contraception? Is a method of contraception used as an emergency step taken before menstruation is missed to prevent pregnancy following unprotected sexual intercourse or expected failure of contraception. Now, these were earlier very popularly known as morning after pill or postcoital oral contraceptives, but now we have even IUCDs which can be used and decrease the risk of pregnancy after intercourse, but before establishment of the pregnancy. Also known as postcoital contraception is therapy used to prevent pregnancy after an unprotected or inadequate protected act of sexual intercourse, decreases the risk of pregnancy after intercourse, but before establishment of pregnancy. I'm repeating it again and again because here is something which I wanted to convey, that emergency contraceptives are not abortifacients. And it is most appropriate terminology as it is self-explanatory. There is the need for urgent and timely action. Need has arisen from an untoward incident, that is the contraceptive accident has happened. There's been a sexual assault, or unprotected intercourse. You've gone out for a picnic, you've gone out with your family, and you suddenly find that the contraceptive is not available. And that's when the emergency contraceptive helps. And it is not meant for a routine use or repeated use. You must, once you've used emergency contraceptive, there has to be a backup method along. So in what situations can it be used? Can be used after intercourse when no contraception was employed, method was used imperfectly. That means that the condom had slipped or broken, or the injection was missed. The injection means that the progesterone-only injections were missed. Sex was forced without the use of a contraceptive method. They are indicated when no method was used, incorrectly used ultimately, and the method was correctly used but immediately observed to have been failed, which we spoke about the condoms. Now, what does a contraceptive method means? It prevents pregnancy by occurring after an episode of unprotected intercourse, does not interrupt an existing pregnancy. Thus, it is not used as an abortifacient. That's again and again what I'm going to emphasize. To be effective, it should be taken within a specific time frame. If you take it little later than the time frame, then there's 100% chance that the pregnancy can occur, and these become ineffective. Not meant to be used as a regular contraceptive, but as a secondary method and as a method in the scenarios which we discussed earlier. How does it act? It mode of action is dependent, according to the day of the menstrual cycle, time in the menstrual cycle that EC is taken, and the type of the emergency contraceptive which has been taken. It works by disrupting the timing of ovulation or preventing the fertilization of an ovulated egg. It is not an abortifacient. So we find that if 100 women, no ECP was taken, 8 pregnancies are going to be there. And if they've taken progesterone only ECPs, then 1 pregnancy, and combined oral is 2 pregnancy. That is the effectiveness of the contraceptive pills which has been published. The available methods to us are, as far as the emergency contraception is concerned, selective progesterone receptor modulators. We have progesterone only tablets, we have combined progesterone estrogen pills, and we have a copper IUD. The timing for the use of each is very different. The selective progesterone receptors can be used up to 5 days, progesterone only up to 3 days, and the 2 tablets of the emergency pills can be up to 3 days, but effectiveness, always remembered, is as early as possible taken. Rather, the best time is actually within 24 hours of the requirement. The combined contraceptive pills could be taken up to 5 days, and the copper IUCD within 5 days of the act. So the common situations in which by a woman has to routinely take them is that oral contraceptive pills, a woman should consider using an ECP after the sex is, she started the method later in the menstrual cycle, she did not use the method consistently, or she used the drugs that might have reached the effectiveness little later. Progesterone only injections, she starts the method later in the menstrual cycle again, or she misses on her pills, on the injections. The implant, the period of contraceptive protection from the important implant and ended before the act of the sexual act. Then intrauterine device has already been expelled out if she was already using it, and it cannot be felt, the string, cannot be located. The condoms, they can break, they can slip, they can be applied incorrectly. Then we know the other methods also. So we should consider that ECP to use depends on a number of factors, including the timing of the presentation and also the patient factors like obesities, allergies, concurrent medications, and also the availability. So the timing of the unprotected sexual intercourse is if it is, while all methods are highly effective within 72 hours, that is LNG IUS can be administered before 72 hours, And the copper IUCD does not decrease the efficacy even over 120 hours. The patient factors which are important is that while the BMI is 30 kgs per meter square is not considered a contraindication, but the effectiveness of the ECP can be there, correlated. Then the patient factors is in case if she's taking any of the medicines like antifungal, antitubercular, anti-epileptic drugs, which decrease the or interfere with the progesterone. So looking into the story of the ECPs, when was it first started? 1967. Then it was again resumed as the USP regime in 1974. I remember, when we were PGs, we used to give our patients combined oral pills and very high doses, 2 in the morning, 2 in the evening for 4 days. And they were really terrible, pathetic, leading to a lot of acidity, nausea, vomiting, headaches, and migraines were always there. In 1975, the progesterone-only postcoital pills were there. In 75, again, we did talk about the copper IUCD, which was first studied as an emergency contraceptive. It was in 1980 that the UZP regime became the standard for the treatment. In 1998, the regime was there, but it was gradually withdrawn because we had this new molecule of levonorgestrel, which was then started widely being used. And in 2003, China was the first country where misoprostol was also registered for the use as an emergency pill. And looking in India, the Ministry of Health and Family Welfare introduced the ECPs in 2002. And I remember down south, on a lot of these buses and all, it was always mentioned about the ECPs. And we did find that it was, then publicized a lot. Less than 1/3 of women were aware of the ECP, but less than 1% have ever used it. The data from 8 states covered that showed a continued very low use of the ECP. So this is, where we as consultants really now should start working up on the encouraging our women to use the ECPs. What are they available? We have oral ECPs available as well as the intrauterine device. The oral is progesterone-only pill. Ulipristal has recently also been used. Mifepristone, combined oral contraceptive pills, and the intrauterine devices. Talking about the combined oral contraceptive pills, there's that conventional UZP regime can be effective given 100 micrograms of estradiol and 1 milligram of norgestrel or 0.5 milligrams of LNG as 2 doses 12 hours apart within 72 hours of the unprotected intercourse. Earlier, the off-label prescription was always there, but now we can easily use them. Should be reserved for situations where people can't obtain the other ECs and for 2 to 3 days also. This was UZP method was an old one, which I spoke about when we were PGs and were doing that. 2 pills each containing 50 micrograms of ethinyl estradiol and 0.50 milligrams of norgestrel or even 1.5 milligrams of levonorgestrel within the first 72 hours. This treatment is repeated 12 hours later. This method works by delaying or inhibiting the ovulation when utilized during the first half of the menstrual cycle. It is only effective if follicles are not already well developed. A lot of studies have been done for this method and their efficacies and failure rates have been seen, but the UZP method somewhere had 1.7% of the failure rate. Looking into the studies which have been done, which was one of the studies way back in 1997, which was done, and we still quote about it, that the regime fails in about 2 of women who use it correctly. Despite that, because there are a lot of other things, like earlier I mentioned that the follicles have been formed or they have not been formed. The side effects were there: menstrual bleeding, myalgia, increased risk of VTEs had been observed. Then we came up with these progesterone-only pills. That was levonorgestrel, 1.5 milligrams. The most studied drug it is, and available in 2 doses of 0.75 milligrams. Each one dose is, actually they come as single dose is favored. They prevent ovulation if taken in the pre-ovulatory period by blocking the luteinizing hormone surge, thus inhibiting follicular development and egg release. It is licensed up to 72 hours, and off-label it can also be taken about 120 hours with established efficacy. Levonorgestrel is progesterone-only pill and a single dose, which I mentioned earlier. In order to be effective, it must be administered before the LH surge begins. Thus, reasonable to interfere with LNG is less effective than given closer to the time of ovulation. There are various randomized controlled studies which have been used, but I feel that the efficacy of LNG decreased with time. In case if it has been taken later after 72 hours, its efficacy certainly decreases. So we need, in case if we need, we can't, figure out as to really the efficacy decreases or what, unless, we increase the dose and double it to 3. But then the side effects become a little more, especially the arterial or the venous thrombosis. The effectiveness, side effects of the levonorgestrel has been that they do cause dizziness, headache, nostalgia, but the nausea, vomiting have really been terrible. Disruption in the menstrual cycle patterns can happen. They can have periods very early, which might be very light or they might be very heavy, and they can have even periods very late. So they are always, in the process of thinking, am I pregnant? Was it a failure? And they also come to us late when they really find that the pregnancy test is positive. Mifepristone in a dose of 10 to 25 milligrams can be taken. A meta-analysis was done in 2019. It reported that it is as effective as LNG and more effective than the UCP regime. So looking into the efficacy of this, we find that there was a study published in Lancet way back in 2002, that they studied low dose mifepristone and 10 milligrams to 1.5 milligrams of LNG, and they found that both of them, there was no difference in their efficacy. Ulipristal is another dose. It is selective progesterone receptor modulator. Dose of 30 milligrams can be used up to 120 hours. Acts by inhibiting follicular rupture even after the level of the LH hormone has started to increase. Progestin containing contraceptive should not be used with UPA or 5 days after that administration, because it can interfere with the effect of that medicine. Copper T, we all know, and has been spoken earlier also, is one of the most effective method, and it can be used up to 5 days of unprotected intercourse. Has an advantage of having an ongoing contraception up to 10 years. Both pre-fertilization and post-fertilization action is there. It acts by preventing the fertilization because of its
Sorry to interrupt, madam.
I'm about to finish. I'll leave this thing. Side effects of the IUD. Most common side effect with copper T are pain during the insertion process, and we also know that there's limitation. You might not find a trained health provider who can help you out in inserting it immediately. We know that the counseling points about the EC is always the gather approach, which should always be there. And we should use the medical eligibility criteria wheel. There's also an EC wheel which is there for counseling of the women. And the factors affecting the use is that it requires the exact knowledge, should be appropriately used and timely used. There are special populations where it is safe, adolescent, breastfeeding, and LNG passes into the breast milk in minimal quantities. So even a breastfeeding woman can be taken, can take it. When you've used an ECP, menstruation within 7 days of the expected period, if it is there, then we ask her to take some other method with it. And if it is not there, the pregnancy test should be performed. If negative, wait for another week. And if positive, counsel the patient. So we have a lot of failure rates and for other ECPs also. And the common concerns are, can you prescribe in advance? Yes, of course, we can prescribe them in advance. Can oral ECP used again in the same cycle? Well, I would say no. And I would say that we explain to them that they should use some other contraceptive method after that. If oral medication is vomited, It is rare after these medicines, but you can repeat within 3 hours of that. And what happens to the menstrual cycle? They can become irregular. Routine counseling should be there in a follow-up care, and pregnancy test should be performed if it is delayed. And if pregnancy occurs, she can continue with the pregnancy. We don't have to be hyper about terminating the pregnancy, because we do give progesterones otherwise also during the pregnancy. Does it interfere with future fertility? No, it does not. Foxy did give out a statement in 2003 concerning the ECPs that they should be widely used. Media did cover them wrongly, but well, that's all right. Need of the hour is to increase the use of ECPs in the basket of contraception. And summarizing here that the EC refers to products that prevent pregnancy. UPA is more effective than LNG, and we also find that the body weight influences the use effectiveness of that. Concluding over here, the available methods of emergency contraceptive in India, the UZP regime, the high dose levonorgestrel, and the copper T. The treatment must begin as early as possible. I feel 24 hours, but within 72 hours it should be. The earlier emergency contraceptive treatment is started, the more effective it is going to be. Mifepristone in low dose and copper releasing IUDs are highly effective. That's it. So this is all about the emergency contraceptives. We have been using more of these LNG IUS also sometimes instead of a copper T to be used, because that also leads to a backup method for that. Thank you very much.
Thank you so much, ma'am. I request our chairperson to kindly give his expert opinion.
Thank you, madam, for informative and elaborative lectures, which is the need of hour for the younger generation also. And thank you for the showing the roadmap right from the beginning till date, and how media to get misleading by Foxy statement. Thank you, madam.
Thank you very much.
Madam, Dr. Ritu, can you stop sharing, please? Stop sharing.
Okay, I'll do that. Thank you very much.
Madam, thanks. Special thanks from my side, Ritu ma'am.
Thank you.
Because
My pleasure.
you always inspired me to work for this committee.
My pleasure.
And you paved a path, which we have been following. So
fantastic.
You did wonderful work in your chairpersonship, and you really inspired.
I think you've done more than what I did, and you're continuously doing it. There's
It's
no doubt
only
about
because
it.
you inspired me. Thank you so much, ma'am, for coming today. Thanks a lot. Yeah.
Thank you so much, ma'am. So with this, we move on to the last session of today's day 2 course, which is the reverse panel on contraception conundrums on special situations. So to moderate this session, I would like to invite our moderators, Dr. Seema Hakim, who is a professor at AMU, and Dr. Kavita Agarwal, Associate Professor at VMMC and Sankalp Champion of Family Welfare Committee and Course Coordinator for this ICOG course. Welcome, moderators. I request you to kindly introduce the panelists. Ma'am, your voice is breaking. Seema, madam.
Hello.
Yes, ma'am.
Yeah, I'm in
ऑडियो थोड़ा सा प्रॉब्लम है सीमा जी. हाँ, तो इंट्रोडक्शन इनको खत्म करने दीजिए, जल्दी से हो जाएगा, फिर आप क्वेश्चंस आप ले लीजिए. कविता जल्दी से इंट्रोड्यूस कर लो.
Dr. Reju, can you please share the slide?
Sure.
The previous slide. So for panel discussion, I would like to invite the panelists. Next slide, please. Dr. Reju Chimote. She is a fertility specialist and cosmetic gynecologist and a Sankalp champion, and also the co-coordinator of the today's program. Next slide, please. Dr. Nibha Mohan, she's consultant Renu Maternity Center, Patna, and honorary secretary, Patna Obs and Gynae Society. Next slide. Dr. Munjal Pandya, he's associate professor, Narendra Modi Medical College, Gujarat, and is the president-elect of Ahmedabad Obs and Gynae Society for the year 25-26. Dr. Chetna Ramani, she is a consultant, Ramakrishna Care Hospital, Raipur, and the Nest Mothers Clinic, Raipur, and a field of interest in adolescent and critical obstetrics and contraception. So I invite all my panelists. And as it is a reverse panel, so the panelists can start. We could see your slides.
Yeah, yes.
Just fire away very fast.
Yes.
This needs to be fast.
Just
Yeah.
started from
Very
case
good.
5, case 1. Yes.
Yes. So a very good evening to all. I'll start with my first case. A 32-year-old para-2 living to A2 woman taking insulin for type 1 diabetes for 15 years. She's scared of sterilization procedure. And on examination, her blood pressure was 150 by 98 mmHg. Her BMI was 29. So what are the contraceptive choices for this lady? Dr. Kavita?
Yeah, so in this case, whenever we are having medical disorders, we should first look at the MEC criteria, which is the medical eligibility criteria. If we see category 1 and 2, category 1 is that anybody can use it. Category 2 is advantages over the risk. So 1 and 2 is that you can use it, whereas 3 and 4 are, 3 is, please can you show the question slide? 3 and 4 is 3 is when the risks are over the advantages, and 4 is not to use. So we have to basically concentrate that we are out of this 3 and 4, and 1 and 2 are in. So now taking this one by one the issues, here there are two problems. Age is fine, that it is 32. BMI is fine. We are pretty okay with these two. The other two things are diabetes and hypertension. So starting with diabetes. If I see diabetes, what the MEC criteria says that whether it is insulin dependent or non-insulin dependent, all the contraceptive choices can be given. But if the diabetes duration is more than 20 years, or if it is associated with any vasculopathy like nephropathy, neuropathy, then combined CHCs have to be avoided. Whether CHC is in the form of the pill, or it is in the patch or the ring or injectable, CHCs are out of it. Also, injection DMPA is out of it. So in this case, as it is for 15 years, and probably she does not have any vasculopathy, so diabetes does not stop us from giving any of the contraceptive. Now we come on to the second part, that is this patient has hypertension 150 by 98. So when we talk about hypertension, what the MEC criteria says that if the patient is hypertensive, the combined hormonal contraceptives, whether again in the form of pill, patch, or ring, or injectable, is again out. Because this estrogen content, it increases the systolic BP by about 8 mm mercury and diastolic by 6 mm mercury, because it induces angiotensinogen, and thus the renin-angiotensin system gets activated. Also, if we see injection DMPA, it disturbs the lipid profile. Therefore, it is said that hypertension is there, combined is out because it has estrogen content. But if the BP is more than 160 by 100, or if the patient has multiple risk factors for cerebrovascular disease like diabetes, hypertension, obesity, smokers, then this is also out, injection DMPA. So now we come on to the case, as we have seen because of diabetes, no contraception is out. But if we see of hypertension, CHCs are all out, plus diabetes and hypertension both are existing in this case. So we won't even give injection DMPA. Now what to give? For that, we have to follow what is called as the gather approach. So G for greet, A is for ask. We have taken the history and we have seen what is the basket of choice. Now we go on to the next, that is T. T says, tell her this basket. So I would tell her she can opt for any non-hormonal method. She can opt for progesterone hormonal method, which can include POPs, or it can include implants. or non-hormonal, that is Chaya or IUCD. This is till T. Now the next is H. Help her to choose. Don't choose for her. Help her to choose. So now again coming to the patient, we see she is 32-year-old and she is with completed family. So I would like to go on with the LARC, that is the long-acting contraceptive, which will include implant, IUCD, and we can have the permanent methods. So now if we see, best can be, if she wants to opt, does not want to opt for sterilization, the option can be IUCD. She can take a 10 years IUCD and then get it changed at the age of 42 years. That is one option. The other option here is, here I would like to mention that the male partner should also be counseled along with the female partner, and also in fact include the other members if required. So don't forget to give her the option of vasectomy, as she is having multiple disorders, to give also the option of vasectomy. Second, it can be copper IUCD. And third, we can also give her the option of sterilization, but as it is written that she's scared of sterilization, ask the myths and try to break those myths. This is till here that you are helping her to choose by coming finally to these three options. Still it remains E and R in the gather approach. E is now explain her the method chosen. That is, if supposing I say she chose copper IUD, so you have to explain her how to use this method, what are the benefits, what are the side effects, what is the efficacy, what is the failure rate. And R is, now you schedule a visit for the follow-up to know her concerns, her queries, and also if she is dissatisfied, then explore the reason for dissatisfaction. So this is in wholesome your treatment to ensure that the patient leaves your OPD with a contraceptive, and continuation depends if you do the method-specific counseling and you schedule a follow-up visit. I think that's all about it.
I think Dr. Kavita, you've answered all the leading questions as well, elaborately answered each and everything with the gather approach. I would just like to ask, like here, since her BP, this was just an incidental finding in the OPD. So would you like to, for such patients, would you like to evaluate her lipid profiles considering her BMI is on the higher side? So are those tests mandatory to start her on any contraception?
So it is that the WHO says that you should start the contraceptives with minimum things so that we don't lose a patient. When we consider CHCs, only blood pressure is necessary. And when I talk about IUCDs, only per speculum and a per vaginal examination is mandatory. For the rest of the contraceptives, we don't do anything. Yes, but we should treat the patient as a whole, so we can advise the patient, but not for the start of the contraception. Contraception, the patient should leave our OPD with a contraception.
So very clear message, Dr. Kavita. Thank you so much. We'll move on to the next case. Dr. Nibha. Dr. Nibha.
Before moving on to the next, there was a very important question about gather approach. Kavita mentioned about gather approach in that. So I think we should answer that very, because very what is gather. So if I'm allowed, I will tell.
Yeah, of course,
Yes,
of course.
Yes,
Yes, of course, of course.
In gather, G is for greet client. Once she comes to you,
your audio is not continuous.
Yes, it's
will
breaking.
you be able to make a difference, Dr. Seema? Will you join from the mobile or something?
I think, ma'am, you can stop the video, then the signal strength.
Yeah, if you switch off the video, it is better.
Yeah.
And
is it better now?
It is better
better?
now. It is better
Okay.
now.
Okay, I will switch off my video. So G is greet your client. A is for ask about the family planning goal. What do they want actually? So ask them about their family planning goal. T is for tell her about different methods of family planning, which is also called cafeteria approach, the different method. Then you will have to help her choose one. If she's asking for one method, you will have to explain, and if not fits, you will have to tell. So help her choose one method for family planning. then explain in detail about the method which she has chosen as her family planning method, or whatever the couple have chosen. Then after explaining and helping her and providing her with that family planning method, R is for you plan for a return visit. Like you've given her a method, and R is for planning a return visit. That is what is gather approach. I hope my voice was clear.
Yes, ma'am.
Yes, yes, it was
Okay,
very
so we
clear,
can go
madam.
on to this
Yes,
this
and your
case
message
now.
was also very clear.
So we can go on to this.
Okay, so good evening, everyone. First of all, thanks ICOG team and Foxy team for giving us this opportunity, and especially Dr. Shobha Gudi and her team. So moving to the next case, I'll be presenting to Madam Seema Hakim that my patient, Mrs. X, 42 years, came for contraceptive advice with history of medical termination of 8 weeks pregnancy, which happened 2 weeks back elsewhere in some another center. Now she has come to me and she presents with no comorbidity. Her BMI is 26 kg per meter square. Her blood pressure is also normal, TSH controlled with 50 microgram thyronorm since 2 years, as she says. Menstrual history is cycle is regular, flow is average. Obstetrical history is she's para 2, live 2, abortion 2. Both are term normal delivery. Last child is 8 years old. First MTP she had 4 years back. There's no history of contraception. Now she has come to me presenting with basket of choice for contraception. She says she'll go for a combined oral contraceptive. So, madam, what you will prescribe to her and what will be best for her?
As she has already chosen combined oral contraceptive method as the method of choice, so we can definitely prescribe her combined oral contraceptive, as she has no risk factor or comorbidity. But while prescribing the combined pill, I will see to it that I will prefer 20 pill containing 20 microgram of ethinyl estradiol, and she can be instructed how to take that on a regular basis, not to forget taking at night. She can take every day, and if she does not want menstruation every month, then we can give her 3 packs in one go, and then 7 days gap can be given to her, and she can continue taking that unless she has some problems. And I will also explain to her that maybe in initial few months she can have breakthrough bleeding, but it will settle with time. So like we can give her that. OCP can be given.
Okay, but she's worried about safety also. She asks which is the safest
It
one
is safe.
and how
Yeah.
safe are the contraceptives for her age, I mean elderly female. She's asking this question.
If she has no risk factor, it is very safe. She's a non-smoker, normotensive, and her BMI is also not very high, 26. So, and there is no, while excluding everything, we must have taken her history of thromboembolism, no past history, nothing is there. So it is safe. She can take it till her menopause. It can be given to her. There is no problem. It is
Till menopause.
she can take.
Okay.
Yeah.
Okay. Madam,
So
she's a bit hesitant also. So should we explain the non-contraceptive benefits of the contraceptive measure to her, like in her age?
If like at 42 years, if she is having menstrual AUB, heavy menstrual blood loss, that will be taken care of. She will also have
I think so your voice is not clear again, madam.
Yeah, Seema madam, a little voice problem.
I know.
Yeah. Yeah, please sort it, madam. Yeah.
So I
And,
think we should make
yeah.
her confident explaining the other benefits apart from contraception also.
Yes, yes,
So that
yes.
she accepts it well and she continues it with for the long
Absolutely.
time.
Yeah, yeah. Correct. Yes.
So
Can go ahead.
Madam will.
She'll
Yes.
come back. Don't worry. You go ahead.
Okay. The same patient who was on COC now came after 2.5 years later. Now she's complaining of severe menopausal symptom for 3 to 4 months with all vasomotor symptoms, night sweats, palpitation, disturbed sleep and all. And she's getting no relief with her change in lifestyle also. And she has read about MHT. She has come for the same. BMI remaining almost same, blood pressure is almost same, blood sugar normal, TSH well maintained. So what will be your advice, madam? How should she go ahead
I think
with her
Dr.
contraception
Sina
and with
is
her
not
this
able
problem?
to join. Can we come again on to this question after a moment?
Sure, because they are showing, that's why I read it.
Yeah, no, it's okay. She was
Okay,
here
sure,
talking,
sure,
but I
sure.
can't see her now. I think she's trying to rejoin. So we
Okay,
can come
okay,
back to it.
okay. So we can move ahead with the next
Yeah.
case.
So Dr. Munjal?
Yeah, I think my cases were 4 and 5, but I'll take this up. Madam, Kavita, madam, a couple 25 years old female, Gravida 3, Para 1, Abortion 1, Live Issue 1, and 26 years old male presented to OPD with complaint of 2 months of amenorrhea. Wife was counseled about IUCD insertion 4 months back when she came for MTP at 2 months of amenorrhea, and she was convinced. But today, female complained about her husband didn't allow her for IUCD insertion as he had some myths about IUCD. How would you deal with such a couple? To elaborate the case, ma'am, it's always about the counseling part, as you said, having that gather approach. We would actually counsel in presence of both of them, so that if they have any questions, they'll be having a conversation with us with regards to why they should opt for certain methods and what can be the myth busters from our side. So that's what we usually do. But then later on, what happens is this is a practical scenario where male would try to have her own thinking again, even after those mythbusters imposed upon the female. Now, how as a gynecologist we would facilitate the female with regards to her own choice of contraception. We talk about female empowerment and giving freedom in her own hand with regards to the prevention of conception. But then how to practically approach this particular question, ma'am? Thank you.
So I think there are two things which might have been lagged when she earlier came for abortion. That is, one is the male partner, and if required, the other family member should also be involved in counseling. Second thing is that when she came for abortion, we should ensure that the patient does not leave without a contraception. She should have been given a contraception before she left the hospital. Now coming to this question, now the present scenario, the present is now she had again come with 2 months amenorrhea. So we'll be again doing an abortion, and again, now this time we are keeping the male partner, the female partner, both of them, and we are counseling both. But now again, maybe they opt for a medical abortion. And if they opt for a medical abortion and they want a IUCD, this can be done on day 15. That is the third visit, the follow-up visit. And maybe again we lose the patient because she again will not come after day 2. Maybe the same thing happened earlier also. That she chose IUCD, and on the day, the third follow-up visit, that is on day 15, the patient did not turn up. So now what we should do in such cases, that if the patient is opting for a medical abortion, we should advise her that on the second visit, that is on day 3, when the misoprostol is given, she can opt for any of the methods. That is oral pills, implant, injectables, everything can be given to her. So try to counsel the patient for this, all these contraceptives which can be given on day 3. That is on the misoprostol day, so that she leaves her OPD with a contraception. That is one thing. Second thing is that when we see the gather approach, in the ask, you should ask what does the patient wants, for how much time. Maybe she is having only one child. She wants only for 3 years. A 3 years gap, you can give her implant. So you can counsel her in that way that it's also a 3-year implant and you need it for 3 years. That is also a way of counseling. Plus, now the male and the female partner both are counseled and they will also leave your OPD with a contraception. I think this can solve the problem. So always remember, when you are counseling the patient, when you are giving the whole basket, that is the T of the gather. In that general counseling, plus in the E, that is the method specific counseling, and the schedule of the return follow-up visit, in all these three things, the male partner should be involved. In the follow-up visit also, you should ask their concerns, their queries, their complaints, both of the partners, and also if they are dissatisfied with this method, then explore the reason for dissatisfaction. Otherwise, if you insert the IUCD also, if you insert an implant also, they will go outside and get it removed. So E and R, that is the method specific counseling, and also the follow-up visit and including the male partner also in these two is equally important for the usage and continuation. I think
Thank you so much.
the solution.
Just one more question with regards to the same. If female now wants it and husband doesn't want it, and she asks you that without his knowledge, I want to undergo this particular procedure of IUCD insertion, what would be your stand as gynecologist, ma'am?
I will try to counsel. I will ask her to bring the husband and I will ask him why he does not. I will try to break his myths. I will ask him why he does not, because everything has a solution, but actually what they know, what they have heard from their colleagues or what they have heard from their neighbors. So we need to know. That is the first thing we say in the gather approach. Ask if they have ever used this contraceptive before.
Yeah, but
One of
Kavita, the patient can be given the IUCD. We don't require the husband's, because it's autonomy, no? Her reproductive autonomy, because it's confidential. When we give a service, it becomes a patient-doctor confidence. We need not divulge it. We are under no, we are not bound to tell anybody. Neither is the patient bound to tell anybody. So it's okay. As far as sterilization is concerned, then there is because it is a limiting method, yes, it's a little difficult to go ahead. But if it's only a contraceptive method, I think it's okay, Kavita. What do you think?
Yeah, it is okay, but if she says that that he is fearing, he is scaring, and he is going to fight,
Yeah, busting the myth is necessary. Busting myths is a necessary thing, but we need not wait for an approval or a consent from the spouse. Munjal, what do you have to say? So the idea of reverse panel was that the presenter also kind of counters and also puts his case. Yes.
I fully accept with the fact that a female can undergo not just MTP, even tubal ligation if she really wants. If her husband doesn't agree to that, legally she is allowed to do so. So I totally agree with that. She can have her own choice. She can undergo any of the procedures she wants.
This particular procedure is fine, but as Kavita says, myth busting is also necessary.
Yes, ma'am. Yes.
So if I may ask one question, ma'am. So I'm just putting a case scenario I got last week. So I had a dermatologist friend.
Go ahead.
So I had a dermatologist, since this is a question of a case about IUCD. So a dermatologist friend who had copper T inserted.
So it's not on the slide? It's not on the slide?
Not on the slides. I'm just asking this since we are talking about IUCD.
Then stop sharing for a moment when you're asking. Yeah.
Yes.
Yeah, this will be better.
Yes.
Yes,
So,
this is better.
So she came to me to get her copper T removed. The reason being, she herself had 3 or 4 patients who had come to her for melasma, and they had history of copper T insertion. So because of fear of melasma, she came to get the copper T removed. So how do you counsel, and what are the incidents of copper T, LNG, IUCD which can cause melasma? So how can we counsel such patients?
Is it there? I am not aware of any such association. Anybody is aware? Unless there is...
I think being a dermatologist, I would ask her to explore what can be the reason of melasma in a patient rather than IUCD, because I have not also heard or seen any patient complaining of melasma because
Because
of.
there are no studies after searching. I just found out
Riju, I
hormonal.
think,
Yes.
what did you find out?
Ma'am, just hormonal IUCDs might cause patches in the skin or melasma,
Yeah.
but there are no reports as such. So I just wanted the expert's opinion on this.
Yeah, I will.
Okay. No, if she's anyway, you would have given a basket of choice.
Yes.
If for some reason she is unhappy and this is good enough reason, we can always change her to another effective contraception. At the same time, saying that this is not associated, because this will then carry forward with the stickiness, and copper T will get yet another infamous association of melasma in
Yes,
addition to
because this
everything
was
else.
new
So
to me,
we
so I
don't
thought
want
I
that to
discuss.
happen.
Yes,
Yeah, I
yes.
understand your concern.
Okay.
I don't think it is. Yeah.
I think we should keep both the things in mind. That is, we should try to do the myth buster, but on the side by side, we should also see that the patient does not leave without using any contraceptive, because we are stressing on one and trying to take the myths of one only, and she leaves the OPD without a contraceptive. That
Yeah,
should
that's
not
why offer the alternative
offer
immediately.
all,
Yeah.
and try to help her to
Yeah.
choose. Don't choose for her, but help her to choose.
Okay.
Next, please.
Thank you.
Has Dr. Seema been able to join? Dr. Seema.
Yeah, I have joined. Actually,
Yeah,
I was
thank you.
muted, so I could not speak.
Okay. You take this case now. Go ahead. Yeah.
Dr. Nibha,
Chetana, present.
Shall we continue with Dr. Nibha's question, Dr. Nibha? So,
Okay. So, madam, could you listen this detail
Yeah.
of
Go
same patient?
ahead. Go ahead a little quickly, please.
The same patient who was on COC now came after 2.5 years with complaint of menopausal symptom for 3 to 4 months, like night sweat, palpitation, disturbed sleep and all. And she didn't get any relief with change in lifestyle. She had read about MHT, and she has come for the same, and her BMI, blood pressure, blood sugar, TSH, everything being normal. So what will you advise, madam, since she's already on COC and now she wants MHT?
Actually, I will check it once more that what all modification she has made in her lifestyle. So it is very important to know that. Directly going on to hormone replacement is not the answer to this problem. So what I will ask her to modify her lifestyle is about her diet. Diet which is has low glycemic content and more of fruits and leafy vegetables. So diet modification is one. Then as she's having problem at night, sleep problems, so at what time diet should be, dinner should be taken, early dinner, and at night she should not be eating or drinking water all the time to disturb her sleep. That exercise is very important for her. She can go for aerobic exercise and weight bearing exercise, that is important. Then stress management by meditation, yoga, and other recreational activity which helps her relieve her stress, they are important. Deep breathing exercise is important for her. Maintaining a good sleep hygiene is important. Going to bed on time, not using too much of screen time should be reduced, especially at night. She should not be using mobile phones all the time or sitting and watching television. Those things should be avoided. Good hydration is important for her. If she's a smoker, then of course a smoking cessation, but this client was not a smoker. Then complementary things like vitamins, multivitamins we can give her. For hot flushes, simple things like wearing cotton clothes, and then maintaining a cool ambience in her room, that is
Madam,
important.
if by chance she has done everything and still she is having
Caffeine,
problem.
coming to that.
Okay.
Caffeine should be avoided. Spicy food should be avoided. Then about mood swing, mood changes, she could have psychotherapy. She should have psychotherapy. Antidepressant will help her. So all these things are going to help her. And there are many few clients who will really follow all these instructions. Now, coming on to the question that she has followed everything and still she is having, although on OCP, there is very less likely of having such a severe menopausal symptoms. But if everything has failed, and we have given enough time also, it's not like she comes in 1 week, another week she comes, and then we start prescribing her. We have given her enough time. Enough time has been given, and she has strictly followed everything, not responding. Then we can consider hormone replacement. Otherwise, as a first line, I will never prescribe, and we hardly give them hormone replacement therapy. And most of the women, they are going to respond. And another counseling part is important, and I will definitely tell her that this will go away with time. You are that when they develop menopause, recent menopause will have more symptoms, but as the time passes off, the symptoms are also going to go away. So we should not be that liberal in prescribing hormone replacement. Rather, we should try other things.
So it's around 45 to 46 years. So she asked like till when she should continue the OC pills. So any age?
Yeah, that's a very good question. Actually, she has developed these menopausal symptoms for the 3 to 4 months time. So at least for 1 year, we are going to wait. In this case, as she will have withdrawal bleeding, it will be difficult to say about menopause when she has attained menopause. But we can go for a FSH level estimation, and more than 40 FSH level in 2 months, like 2 months apart, 2 level which are more than 40, we can say that she has attained menopause, and we can stop after 1 year, we can stop OCP.
Thank you so much, madam.
Yeah, Ritu, can you just go towards conclusion? It is getting a little late.
Can I say something about this cancer survivor contraception?
Yeah,
for
she is
cancer?
presenting. She is presenting. Chetana has to present.
Yeah.
You can take the question. Yes.
Yeah. So good evening, everyone, and many thanks to get me involved. I would directly go for the case, and this is Mrs. X, who is 31 years now and para 1, living 1, and she is diagnosed with receptor positive, ER/PR positive breast cancer, which was stage 1 to 2, and that too at the age of 30 years, a year ago. And now she has finished her chemotherapy treatment a month ago. So she has come to you. She wishes future fertility, she says, but she wants reliable contraception now.
Should I
So
say?
what are her
Yeah.
contraceptive? So what are her contraceptive options with this history?
Dr. Seema, please.
Yeah, intrauterine contraceptive device can be given to her, or a consistent and persistent use of condom by husband, that can also be advised to her. We will not give her hormonal contraceptive because she has been recently treated for CA breast. So not a good choice. Any hormonal contraceptive, that should be avoided in this case.
Madam, so whether it is, even if it would have been a negative, triple negative breast cancer, in that case?
No hormone, no hormonal contraception in a recently treated case should not be a choice. Only if she has been cancer free for 5 years, then we can think of giving her LNG intrauterine device, because that will take care of her therapy, which she is receiving. No, endometrial hyperplasia will not be there. But another contraceptive choice which she can be offered is Centroman. Centroman has beneficial effect for therapy of cancer breast also. So Centroman can be tried, though I could not get long studies on Centroman, but we can prescribe her Centroman also.
So basically, what we can see is we don't have any proper guidelines, but these are just good practice points where they suggest that even if she is like a hormone positive receptor, I mean, hormone receptor positive, in some special cases, you can still consider hormonal contraception. So what do you say, madam?
Yeah, only if she is disease free for more than 5 years. That too, it is in medical eligibility criteria 3. We are talking about CA breast. There are other malignancy also wherein contraceptive will be required, especially young women having choriocarcinoma and germ cell tumor. Those are also the cases which should have been included, because CA breast we get, but not at a very young age. But at a very young age, the cancers which we are getting and the patients are surviving are choriocarcinoma and malignant ovarian germ cell tumor, wherein oral contraceptive pill can be advised till the time that they need fertility. And the other malignancies which we should have talked about are carcinoma cervix and carcinoma body uterus. Carcinoma cervix mostly we get in the multiparous women, and the therapy itself leads to no fertility later on. Like if she's getting radiotherapy, she's unlikely to have fertility. But for CA body uterus, as more and more patients are elderly patients, they are wanting for infertility treatment, and the incidence of PCOS is also rising, and we are getting cases of CA body uterus where for some time they need to have contraception, and later on fertility is required. So because of shortage of time, we can't discuss in detail, but those cancers should also be kept in mind when we are talking about cancer survivor and contraceptive.
Yeah. So are we taking conclusions here? Case 5. Okay. Can we be a little more crisp and brief in the responses, because use it more as a rapid fire?
Dr. Reju, you are mute.
Yeah, should we continue with the remaining 2 cases, madam?
You can just take it as a rapid fire, that's all. Just take another 2 or 3 minutes to wind up, because people are waiting for the post link.
So Dr. Kavita, a 21-year-old married for 2 months, she needs contraception.
Just give one-liners, please. Yeah.
So a patient with on anticonvulsants, what would be the preferred method of choice? Can she take pills, and what are the basket of contraception for such
In
women?
this case scenario, we can see that the patient is epileptic. She is on tap carbamazepine, which is an enzyme inducer. So in enzyme inducer, if we start with the oral pills, their bioavailability is going to decrease, and finally the patient can have the failure of contraceptive. So you remove the oral from your basket, rest all the basket you can give to the patient. Whether it is injectable, whether it is implant, or it is IUCD, all is for her except oral.
Only one reservation is about the implant. That also may get, the efficacy can get affected by or the enzyme inducing anticonvulsants.
So
But then, yeah.
If a similar patient on anticonvulsant, but her seizure-free period is hardly a week or so, in such cases, will there be any difference in prescribing?
I think preferably in any medical disorder, I will go with copper IUD.
Yes.
But if the patient insists on, then you can give, but then again avoid oral. That is the best. But preferred in any medical disorder, the rule goes as non-hormonal, you have Chaya as pills, but then again no to the pills. So no POPs, no CHCs, no pills, whether it is Chaya or anything.
Yes, ma'am, rightly conveyed the message. So we'll move on to the last question, last case scenario, Dr. Munjal. So
yeah, just in one sentence, if the husband is not willing for going ahead for NSV, non-scalpel vasectomy, which is quite a shorter procedure, in a lot of indications, we would require the husband to undergo this particular procedure, because at times the female is not fit enough to undergo certain procedures. So in those cases, what are the points which you would like to use for counseling purpose of the husband, ma'am? Yes.
So first thing I would like to say, even if the patient is healthy enough and she is able for contraceptive, we should offer in the basket the vasectomy, because we have to involve the male contraception also. Secondly, in this case, it was a ruptured ectopic. And I think if it is a case of ruptured ectopic, or it is a case of cesarean section, or we are doing a surgical abortion, then we should offer the patient at least a tubal ligation if she is having completed family. So this was one mistake which should have not been done, then where the patient was operated for a ruptured ectopic, but the tubal ligation was not done, or she was not counseled for it. Otherwise, it would have been done at the same sitting. So that is one thing. If you are operating a patient, a cesarean, a ruptured ectopic, or a surgical abortion, make it a point that you counsel her for tubal ligation. But now, if the patient is undergoing medical abortion, or she is just having a completed family, and now the husband and wife, they walk into your OPD for a contraception choice, then do not forget to give the vasectomy as the first choice. Now, to explain her, to convince the couple for the vasectomy, for the male for the vasectomy, the few thing is that you have to tell her, it is also tell him and her both that it is a permanent method of contraception. It has a failure rate is very less than 1%, so it is very effective. Also, the third thing is that it is very safe. It is no scalpel, no incision, does not need any anesthesia. Only local anesthesia is more than enough. Also, you have to tell that it's not going to affect his orgasm or the ejaculation. Because we are not handling with the nerves and muscles.
Correct.
So he's going to have a normal ejaculation.
कविता, ये NSV पे कल सेशन है बेटा, वो ये पूछ रहे हैं आपसे कि हम इसको क्या कैसे टैकल करें अभी. The male is not ready to come for NSV.
Yeah,
So
He's not taking up.
What I mean,
He's not
say
ready.
that
You have counseled,
he
but
is
he's not ready.
He is not going to lose the orgasm. He is going to ejaculate. The only thing
नहीं नहीं बेटा, हो गया, सब कुछ कर दिया आपने. You have already told him everything. He's not ready. So Munjal wants to know what to do now. This woman is having.
Actually, can I say something?
Yes.
Yes.
In this case, actually, she has already suffered with ectopic gestation, and why was her ligation of other tube not done? Maybe they did not give consent. Now I am going to counsel the husband that your wife's life is at risk because she has undergone surgery for one-side ectopic pregnancy. All likelihood that she will have another side ectopic pregnancy also in future. So better to use some.
So they are already fighting,
and
Seema.
then different choices will be given to them. Otherwise, like, if husband is not ready, you will have to adopt different method, counseling method, to tell him that if he does not listen to
let us throw
wife
this
is
question
at
to the
risk.
audience. Let us stop sharing the slides. Thank you very much, Riju, for the fantastic presentation. I would like this question to be thrown to the audience. And I think Munjal has brought a very pertinent question.
Thank you.
What would you like to do?
Okay, after this, again, one more question I wanted to ask with regards to surgery.
But without slide, because there's no time.
Yeah, without slide, yeah.
Anybody wants to, there's no time today for anything. Only test will be done. And after exactly 2 minutes, anybody wants to answer this question from the audience? What is the next? So there's something known as converting the limiting method. There's something like converting the limiting method, because this is a situation where limiting method is very desirable, either for the woman or for the man. But both is not possible, not acceptable, not feasible. So convert limiting method need to LARC.
So anybody
LARC
from
is
the audience who wants to answer this question, kindly raise your hand. We'll unmute you accordingly.
Correct.
Yeah.
Anybody wants to answer? Yeah. So convert, somebody are using, advisor COC, will not return to OPD, give anti, okay, implant DMPA. So those are the correct answers. You must convert this to LARC methods. And one of the best LARC can give Poonam, but in couples who have finished family, to give them spacing method, short acting method is a little bit of a challenge. If you convert it to LARC, it will be better. This case,
see, this patient is also 24-year-old. So I think 10 years IUCD can be an option. We can tell by going to 40 years, she will need to change IUCD only twice.
Yes. So, or even 3 to 5 years does not matter. Does not matter. If she can get it changed, why not? I think IUCD is not contraindicated here. So no fear of contraindication, even if there is an ectopic pregnancy. That is the message we wanted to give.
But
convert
madam,
this situation to LARC.
Ectopic has been operated 2 months back only.
We can still apply. We can still give. There is no problem if she is resumed periods, IUCD is an option. Yes.
Should rule out the pelvic infection. That is why we
Yes, that's all.
PV
Yeah.
examination.
Yes. Sir, of course, you have to rule out pelvic infection without going. Yes. Yeah, we can now conclude. Munjal,
Just
or you
one
want
more
to
question.
throw
Yeah,
one liner? One liner.
one liner. 34 years old female. If this has been the case of 34 years old of female, family completed, ruptured ectopic. Now the same scenario with hemoglobin 5. Now would we go for tubal ligation of the other tube with 5 hemoglobin? Because to my knowledge, if we are actually going ahead with tubal ligation in such a case,
No, it's contraindicated.
yes,
It's ACDS criteria. It is delay. Okay, what
okay.
you want to do, but
But then again, the same question, huh? Then we need to counsel husband for NSV. That's it. Nothing else. Thank you.
no, you can give them
He is
DMPA
not
because they are
ready now.
excellent methods for LARC. Yeah, chalo.
Yeah,
we
thank you.
will give the post test link. So
Thank you.
silence everyone. Today the post test link will stay for 15 minutes. So we will talk to you again after 15 minutes, exactly at 7:30. Thank you very much.
Thank you so much.
Yes, Sudharani, we can correct anemia, which is a priority, and then we can give her LARC. I agree with you. Yes.
Because except caution, delay, and special, we have to go
Yeah,
through.
ACDS. You have to follow AC. Yes, Kavit.
Yes.
Tomorrow it will come. ACTS will come tomorrow. Yeah.
Sharing the post test.
Involving us in this. Thank you.
Please start. Silence everybody.
Yes, I'm sharing
Finished.
the post test. The link will be there for 15 minutes. You can scan from this. Can I have the tech team to kindly share the link as well in the chat box?
I'm already done.
Already done? Okay, thank you. So you can either scan this QR code or click on the link in the chat box.
Here's the link, but yes.
It's in the chat box, mom. So
Yes,
those who
yes.
have joined later, the attendance for all. So this is
Ma'am,
day 2
please
of the
share a scanner also,
Yes,
ma'am.
yes.
Yeah.
So for those who have joined later, I would like to tell you that the attendance is compulsory for all the 3 days of this Foxy ICOG course. And those who have attended the course and passed with at least 50% marks on each day, they'll be getting the certificate from ICOG, and the certificate will be sent within 1 month. So we have last 30 seconds remaining. I hope most of the audience have completed their post test. Shobha ma'am, there's a query. Two of the audiences, they have asked, they could not complete their post test yesterday. So I hope everybody is done with the post test.
Riju, we declared the last minute, Riju. Last 2 minutes.
Okay.
No, did we declare last 2 minutes?
I declared the last 30 seconds, madam. So
fine. That's
it was
fine.
there on the screen.
Yes. Then that's done. That's wonderful.
Yes, ma'am.
Yeah.
So there was a couple of queries since we had already told that 3 days post test is mandatory. There are some audience who could not attend the post test yesterday. So can any?
Yeah, I think that will be a decision to be taken by ICOG office. I request Vanita and who else who are asking for it?
I think
one more person. No, Vanita has asked and other people have asked. Please write a individual mail to the office, Foxy office. It is foxy@icog.org. Nilima, can you type it into the chat box, please? Okay, Shubha Patel has a problem. It is not accepting response. Shabnam also has asked for yesterday's. Question number 1 appears to be wrong, is what Manjur Aura says. We'll soon come to the questions and then we will see. If it is indeed so, then we'll disregard the question. No problem, Manjur, no worries. Because anyway, we had seen all the questions once. Okay. Ishani Sachdeva, points which you get in these certificate can be used for getting after fulfilling other requirements. The certificates might help, I guess so. Okay, Shaveta and one more person not accepted. Shubha Patel, Shaveta has not, the response has not been accepted. Host, can you help them, please? Madhuri Saha also.
Meanwhile, ma'am, can we share the answers?
Because if you share the answers, then how will they submit? Give another minute or so. Let the host respond. Host, why is it not accepting? Is it because of internet issues at their end?
Ma'am, after 15 minutes, it will not take the answers.
Yeah, but that is something which we discussed yesterday, no? That you must extend it for 2-3 minutes beyond. Because if we say 15, then they are likely to stop responding at 15 and then submit, right? So at least 2 minutes grace you should give. Yesterday also I had told Nilima.
Okay, ma'am.
So this is, they will all write individual mails. You please respond to that, because I can't help this, because we are conveners. We are not at the back end at the office, and it is the office bearers who will have to decide, right? No, ma'am, I submitted before 15 minutes is what she is telling. 10 minutes she is submitted. Time is over. That's why it is not accepting, is Suma is telling. Okay, I am not able to resolve this issue. You must excuse me and forgive me for that. And Shaveta has done within 15 minutes. Okay. Deepika, many people are asking for the answers. So that is where we stand. We are not perfect. So have not given the test yesterday. Kindly share email. Okay. Please write personal mails to Foxy. Can you share the mail ID, somebody, please? I'll put it in the link. I'll put it. You go ahead with the answers, please. Yeah. Please go ahead.
The
Riju?
text is not very clear. So I'll start with the answers. The first question was, so there are queries regarding the first question not being correct. So the first question, ma'am, Shobha ma'am, can you please elaborate on that? Following
You read it.
What instruction should not be given to the client? Option 1, she should be told to come back to health facility soon as there is any problem. She should feel the thread with fingers after each menstrual period, which was given as the correct answer. And
Yeah, so there is a negative in the stem, no? So that means she should not feel the thread.
Yes.
That is why it is the correct
That is,
response.
yes.
Yeah.
So if the second question is, if the client develops reproductive tract infection any time after IUCD insertion, what should be the next course of action? So the answer for this is appropriate antibiotic treatment and reassurance to be given, and client can continue with IUCD. That is B. The third question was, in which of the following conditions IUCD can be inserted within 10 minutes after placental delivery? That is, answer is option B, history of rupture of bag of water membranes 3 hours before the delivery.
So all are false.
All are false.
Sorry. No, this one. No? In which of the following conditions IUCD can be inserted? Yeah. Correct only. That is correct.
Yes. So
why is the clarity so less, host, please? Why are they seen so badly? Hello?
Shreya, can you...
Actually, ma'am, network issue is there. That's why.
Okay. So no problem. So question number 4, all are false except option A was, apart from its use as hormone therapy, tamoxifen can be used as reliable contraceptive. Option B was, combined hormonal contraception can be freely offered to patients who have had triple negative breast cancer. Option C was, non-hormonal contraception should be first line option for individuals who have or have had CA breast, and option D was, for women over 5 years post diagnosis of CA breast, COC pills is categorized as MEC4. So all are false except option C, which is non-hormonal contraception should be first line option for individuals who have or have had CA breast. So moving forward to the fifth question, what is the effect of oral contraceptive pills on the risk of endometrial and ovarian cancer? The answer is it decreases the risk of both. The sixth question was, a woman taking rifampicin is advised to use an additional contraceptive method along with her oral contraceptive pills. What is the reason? The correct answer is option C. Rifampicin induces hepatic enzymes, reducing contraceptive efficacy. Seventh question was, which of the following is an absolute contraindication for IUCD insertion? A, nulliparity. B, age less than 20 years. C, current PID. D, history of ectopic pregnancy. So the correct answer is C, current PID. So eighth question, a 28-year-old woman presents for contraception. She reports lower abdominal pain, fever, and foul-smelling vaginal discharge for the past 3 days. On examination, there is cervical motion tenderness and adnexal tenderness. Which of the following is the most appropriate next step? The correct answer is defer IUCD insertion and treat for PID. So the rest of the options were insert copper T, insert LNG after completing IUCDs, and fourth was reassure and advise follow-up in 1 month. So the ninth question was, a 34-year-old multiparous woman wants long-term contraception. She has a history of treated breast cancer 1 year ago and is currently disease-free. Which of the following contraceptive options is contraindicated? Copper IUD, LNG IUS, barrier methods, or tubal ligation. So the correct answer is, correct answer is LNG IUS. The next question was, a 32-year-old woman with well-controlled epilepsy on carbamazepine wishes to use contraception. Which of the following is the most appropriate method according to WHO MEC? And the correct answer was is option C, that is copper IUD. The 11th question was, a 40-year-old women with BMI of 38 and well-controlled hypertension seeks contraception. Which of the following is contraindicated as per WHO MEC? The correct answer is C, that is COCs. Question number 12, a 40-year-old woman with BMI of a 28-year-old woman with SLE and positive APLA wants contraception. What is the WHO MEC category for the combined hormonal contraception in her case? The correct answer is option D, that is category 4. A 35-year-old diabetic woman with vascular complications is considering contraceptives. Which method is safest according to WHO MEC? The correct answer is LNG-IUS. A 25-year-old woman with history of DVT not on anticoagulant seeks contraception. Which of the following is contraindicated? Progesterone-only injection, LNG-IUS, copper IUD. The correct answer is option C, which is combined oral contraceptives. Question 15. Insertion of IUCD is not recommended in which of the following condition? That is option B, women having pus-like discharge from cervix. Question 16. If IUCD LNG-IUS is noted to be malposition non-fundal, which of the following is correct? Remove IUCD as there is high chances of expulsion. Reposition IUCD using artery forceps. Explain that the patient may get pregnant. The correct answer here is removal is not necessary as long as the IUCD is above the level of internal loss. Question 17. Which of the following statement is true? IUCD can be inserted anytime during cycle as long as there is no unprotected sexual intercourse. Sublingual misoprostol may be used before IUCD or LNG-IUS insertion to facilitate easy insertion and reduce uterine cramps. Nulliparous women are MEC category 2 for IUCD. The answer here is all are true. Next question is Implanon NXT is an implant long-acting contraceptive containing. The correct answer here is progesterone. Which of the following is not an emergency contraception? Copper IUD, ulipristal, postcoital pills. The correct answer here is breastfeeding. The last question is how many hours after unprotected sexual intercourse should emergency contraception be taken for its most effectiveness? That is 24 hours, option A. With this, we come to the end of the post-test. Can you stop sharing, please?
I would like to thank Shobha ma'am and the whole organizing team, Parag sir, for having us here. We really enjoyed, and we hope that the PGs and the audience who has been listening must have benefited a lot. I'd like to thank all my panelists and as well as the co-moderator and especially Dr. Reju for helping me in co-coordination for the whole day out so that it worked smoothly. Thank you so much.
Thank you so much. Ma'am, you are muted.
You are muted, Dr. Shobha.
Yeah, please stop the screen share. Yeah. You know, I like this view because it helps us to connect so well. Yeah, I like this view. So brilliant reverse panel by all the experts. Really appreciate your hard work. I only wish that the philosophy of reverse panel had been taken on, you know, like a more charged. Towards the end, it became really nice, but then it should be very crisp. And I hope, of course, you are all you have so many years to come in Foxy, and I know that you will do more and more. And this was quite brilliant in itself. Thank you. I thank Dr. Seema for her senior presence. And, you know, Madam is so accomplished and such a senior teacher. I thank her for her time. And all of you, Riju and Kavita, today was not possible without you. What do you say, Rachna?
Thank you so much, ma'am. I would like to thank...
Rachna, unmute karo re. नहीं सुनाई दे रहा बेटा.
I think
Rachna and myself, we have been on this program for the past more than 1 month, actually 1.5 months. We have been eating everybody's heads, and today. So thanks to the audience. I like the brilliant interaction in the chat box, and I love their sense of discipline. And I really appreciate the fact that everybody has this subject in the forefront of their minds. It is so very necessary for practicing obstetricians, and it is so very neglected. So today we have made some inroads into that. All the very best to Munjal and
Thank you, ma'am.
Nibha and so many others. I don't know who all contestants have joined. Okay, I think it's
Thank you,
time to
Shobha ma'am.
take.
Thank you, Shobha ma'am. Thank you, Kavita ma'am, Seema ma'am, and thank you, Riju ma'am, for coordinating everything and make it flawless. Thank you so much, ma'am.
Thank you.
Yeah, correct.
Thank you, Dr. Shobha, Dr. Riju, Dr. Kavita.
So Dr.
Yeah,
Rachna ma'am has unmuted herself, ma'am.
Rachna, bolo.
Your voice is still not heard, Dr. Rachna. Can't hear you.
कुछ तो हो गया है. Tomorrow you have to do everything. Thank you, Dr. Durga Shankar Das. Thanks a lot for staying till the end, being with us.
I would like to thank Salah.
Dr. Durga Shankar.
Yes,
Thank
you, sir. Pranam, sir. Pranam,
Are-
sir. Thank you, sir.
Thank you.
Thank you so much, ma'am.
We
It's
have done,
nice.
all of you have done so well. I am very patiently listening to all of you.
You're a very patient man. Your wife is very lucky, I think, Dr. Durga Shankar. So many of us talking for 3 hours and you never said a word.
And that too, yesterday only the same status continued. So let us see tomorrow.
Tomorrow, please
all of you
open
are
the
doing
session for us. Please introduce everybody tomorrow. Please take the show forward tomorrow. And we shall all meet tomorrow 4 p.m. promptly. Thank you very much.
Tell the coordinators and Elima to coordinate with me so that I will be following their instructions exactly the way they want to proceed. Okay.
Yes, sure. Thank you.
Bye bye till then.
Yeah.
All the best for tomorrow.
Thank you.
And one message to all young participants, postgraduate students and all, please do not get disheartened whether you have submitted or not submitted. Please patiently go through the sessions, attend it, answer. If you fail to answer, don't get worried. You will be definitely rewarded. We have all soft corners for you. Please have patience, listen and attend the sessions. Tomorrow also till the completion. We are also learning. So lot of things to be learned by you. I heard from so many PG students getting disheartened that their nets are being connected, they could not complete. Don't get worried. We will be coming repeatedly to you. Please have patience, listen and attend the session.
That's very, very positive.
I am having one suggestion that this time limit for this post-test should be uniform for all 3 days.
Yes, Dr. Sanjay. Yeah.
Yeah. Please keep it 20 minutes so that it will be uniform for all 3 days.
We will convey
And
that.
for 20 questions, 20 minutes is rational, I hope.
Usually we take it actually as 30 seconds per question in any online polling or questionnaire.
All are not so expert like you.
No. It's not a question of expertise. It's a question of having listened for 3 hours and then responding. So questions were 15 minutes was reasonable, but in case you want 20, it will be done 20 tomorrow.
Yes.
Thank you. Thank you. Because it's for the audience that we run the show, so it's okay. Thank you very much.
Good night.
Can end the session. Yes, good night.
Good night.
Good night.
Did we take a picture? Yeah. Anybody took pictures?
Everybody puts their video on.
Rachna has taken. Rachna, हाथ नीचे करो, मैं अभी ले रही हूँ. नीचे करो. My goodness.
Can I add one line more?
Yeah. Okay. Tell us. Yeah.
Thing is that we have already completed second day. So we have to follow the norms, whatever. But what just as Dr. Sanjay Swami has pointed out, I have also come across this sort of request from many of our PG students. and they want little bit more time. This is a certified course, not exactly an examination. So, and the next
We'll give.
certified course will be a bit liberal to give you a little bit more time in the post test.
Sure. Thank you.
This is what I believe will be more beneficial and encouraging for them.
We'll do
Okay.
that. Thank you.
Okay.
Thank you, Durga.